Thank you all for your valuable time for the pre-test. Time off. So the answer of the pre-test as follows. Kindly evaluate yourself. First, 1B. Yes. 1B. Yes. 2B. 1B, 2B, 3C, 4D. Yes. 1B, 2B, B for Bombay, 3C, Cuttack, 4D, again D. Okay. What? D, 4D, 4D, ACT score, ACT score. Okay, okay. 5, answer B, the whole night polysomnography. 6A, narcolepsy. Sorry. 7B, mild OSA. 7B, mild OSA. Then 8B, male gender. Sir? Male gender, 8. 9C, Epworth sleepiness scale. 10C, chest expansion. 10C, chest expansion. 11D, cataplexy. 12D, unrefreshing sleep. 13D, the last, after AD, OSA onset is there. 14B, EDS. Excessive daytime sleep. Sleepiness. 15B, in transition state. 16C, sleep spindle. 17A, dreaming. 18A, nightmare. 19B, 3 months. 20B, stretching. 21D, 10 second. 22B, gabapentin. 23D, last, it's not precipitated by dental disease. 24B, the person will have full consciousness. And the last 25, the question is wrong and the answer should be REM sleep. Last, the question is wrong, it should be REM sleep. Yes, ma'am. Yes, ma'am. Which stage of sleep is called paradoxical sleep? NRME stage 1, second stage 2, C stage 3. Yeah. Thank you all.
A very good morning to one and all present here. I, on behalf of Department of Physiology, Sri Jagannath Medical College and Hospital Puri, welcome you all to our CME, a basic course on sleep medicine. It's an honor to be graced by the presence of such wonderful delegates here. It's a pleasure to have you all today here with us. There's a famous saying, a good laugh and a long sleep are the best cures in the doctor's book. Sleep is a natural spontaneous activity in the organism which follows the diurnal rhythm and just happens automatically. We don't have to think about it, but it has become a problem to human beings these days because they have started thinking and worrying about sleep. The more you think and get worried, the more elusive and difficult it becomes because the complexity of sleep goes beyond its structure. Even mild sleep restriction not only affects the cognitive and physical performance, but also the overall productivity and the health of the person. This CME will not only enhance your knowledge regarding sleep, but also help you diagnose sleep disorders more easily. It's a holy tradition to worship our goddess Ma Saraswati before any important event. Ma Saraswati is the goddess of knowledge, nature, music, art, learning, and wisdom. She represents the free flow of wisdom and consciousness. So here we pay tribute to the goddess with Saraswati Vandana. Now, I would like to invite the dignitaries on stage. I'd like to call upon Professor Dr. Maya Padi, Dean and Principal, Sri Jagannath Medical College and Hospital Puri on stage. She has been instrumental to the Institute's journey and progress. I request you, ma'am, to come over the stage and occupy your honorable seat on the dais. Next, I am very much delighted to welcome Professor Dr. Arpita Priyadarshini, Head of the Department, Department of Physiology, Sri Jagannath Medical College and Hospital Puri, who has poured her heart out in organizing this CME. Her contributions in sleep and sleep disorders has been very inspiring. Next, I would like to request our chief guest, Dr. G. Indra, retired professor, Department of Pharmacology, who is an eminent personality, to join us on stage. Next, I would like to invite our guest of honor, Dr. P. Sarat Chandra, neurosurgeon, AIIMS, New Delhi, to kindly occupy his honorable seat on the dais. Sir has 6 patents and 4 publications. Now, I would request all the dignitaries to join us for the lamp lighting. Yes.
शुभं करोति कल्याणम् आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय दीपज्योति नमोऽस्तु ते दिव्या दिव्यारे दीपत्कार कानी कुण्डलमोतिहार दिव्याला पाहून नमस्कार तिळाचे तेल कापसाची वात दिवा तेवे देवा पाशी उजेड पडे विष्णू पाशी माझा नमस्कार सर्व देव देवतांपाशी ये ग लक्ष्मी बैस ग बाजे माझं घर तुला साजे घरातली इडापिडा बाहेर जाऊ दे बाहेरची लक्ष्मी घरात येऊ दे घरच्या सर्वांना उदंड आयुष्य सुख समाधान शांती लाभू दे.
Now, I would request Professor Dr. Maya Padhi, Dean and Principal, Sri Jagannath Medical College and Hospital Puri, to enlighten us with her speech. Ma'am, please.
Joy Jagannath. A very good morning to all of you, respected dignitaries on the dais, dignitaries of the dais, my colleagues, my faculty members, students, ladies and gentlemen. It's a very happy morning today for all of us. because we are going to learn something about a disorder or about a topic which is largely unrecognized and unreported. Sleep disorders, any disorder which makes the sleeping pattern abnormal, contributing to ill health. So now it is being recognized that sleep disorders can actually be the origin of several systemic disorders. So in the genesis of systemic disorders, we have to look for the sleep pattern of that patient. Hence, this CME is an attempt to involve all doctors, especially at the primary level, so that they will know what to look for and identify the basics of a disordered sleep pattern. Sleep has been accorded great importance over the ages. So anyone who has a very peaceful sleep is usually fit and a happy person. This was well recognized in the ancient times in our scriptures. Sleep was thought important enough to symbolize and personify it as a goddess Nidra. So it was felt that it was so important that it needed to be worshipped. So this speaks of the importance of sleep in our lives. We on a personal level also know how disordered and how out of sorts we feel if we have not had a good night's rest. With the increasing stress of today's life, a good, peaceful sleep is becoming a rarity. So these sleeping patterns are changing with the coming of the social media. People watch the different gadgets late into the night, which disturbs the sleep pattern, etc., etc. So today's CME will aim at giving us an understanding about the basic normal sleep pattern and what we should look for in a disordered sleep pattern. We owe our thanks to the Department of Physiology, headed by Dr. Arpita Priyadarshini, who have always been at the forefront of academic activities and value addition for this college, and we are thankful to them for that. And I hope all of you will have a good day today. And to keep you out of your somnolence, she has arranged a lot of, I think, delicious food and drinks in between to keep you all awake. So in tune with the line of the theme of today's. So thank you all and happy learning.
Thank you, ma'am, for your encouraging words. Now, I'd request Dr. Bimoj Pragyampati, Head of the Department of Microbiology, to felicitate ma'am with a memento. Next, I would request Professor Dr. Arpita Priyadarshini, Head of the Department of Physiology, to enlighten us with her ideas regarding sleep.
Thank you so much, Dr. Seema. A very good morning to one and all. Jai Jagannath. And I have nothing else to tell you, but only one thing. Thank you so much for being here. Sleep. I joined Sleep in 2006. Dr. Manjari is here. National Sleep Medical Course, National Sleep, NSMC, National Sleep Medicine Course, yes. In 2006, our gurus, Dr. Hridananda Malik and Dr. Deepak Srivastav from USA, they initiated me. Dr. Manjari was also there as a faculty of that group. So I have been in sleep since 2006. I'm still struggling in Odisha, and you all have come. Our journey will be better. This particular basic course, in the presence of iconic people, star speakers like P. Sharat Chandra and Dr. Manjari, Dr. Sorin, is a great achievement for Department of Physiology and the Institute here in Puri. Well, as you have seen, Madam has said that sleep is a Devi, Ya Devi Sarvabhuteshu Nidra Rupena Sansita, Namastashay, 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 Namo Nama. It shows that sleep is a very important physiological function. And as you see, we have felicitated Madam with Shank or conch that is related to sleep. How? When you blow a conch, your carotid body is stimulated, your vagus is stimulated, your heart rate comes down, and you sleep well. So that is why we have given you, ma'am, we have felicitated, and that's a symbol, and that helps in sleep. We'll be learning a lot throughout the session, and it will end by 5:36. Lot of good food is waiting for us, because Yadevi Sarvabhuteshu Kyuda Rupena Sansita. Two physiological function rules our life. One is sleep, one is food. So with this little words, whatever I have learned from my seniors, no words are mine, all I have learned from my Guru Parampara, from the seniors, from people I have met. We'll be having a great day. Have patience. We have to be with each other till 5 o'clock. Thank you so much.
Thank you, ma'am. Now I request Dr. Manjari Tripathi, neurologist, AIMS, New Delhi, to felicitate ma'am with the memento. Just. Next, I would like to invite our chief guest, Dr. G. Indra, retired professor, Department of Pharmacology, to say a few words.
Hello. Thank you, everybody. First, I thank Dr. Arpita, who has invited me as I was a teacher in the long years of my her journey. So here I have retired at the age of 58. So then I was in several medical colleges, and last leg was in my KIMS. But after that, actually, I have lost the touch with the academic life, though there are some compulsion to go through these books, all these things for some elements in my home or my known relatives, all these things. But it is actually a wonderful day for me, and I will remember it for life till my last end, because I am now at Puri, but I was very eager to visit this medical college, but I didn't. So it was a nice occasion to meet several people and also meet Maya, whom I have seen in my medical college at SCB, and she is still like that. She is a evergreen lady, and she must be very viable in establishing this Jagannath Medical College. So I am, as a Purians, now I am at Puri, so I thanks and welcome. She has been welcomed, but I am, from my sake, I am welcoming. So I have come here just to gain some knowledge about sleep. Actually, in our course, we didn't have any importance of sleep. We didn't know that no curriculum, and in our time we are also not teaching well, because we didn't know about the sleep. Only NRM, REM, sleep, so theta, alpha, beta waves. So all these things just we memorized, and we are telling to our students. So actually I was very much interested when I knew that Arpita is conducting, and actually I met her in another, in Sanskrit Medical College. She gave a lecture on sleep. So I was actually interested to know about the sleep. So I won't take so much of time, but again I am thanking all the faculties and the members who will be as a core member to teach me about little bit of sleep, because my depth of learning is also now becoming slowing. So I just hope that I may got something from this seminar. So thank you again, and I wish that I will also, with me also, you people, those who you have now some little bit of knowledge of the sleep, will gain much. So thank you again.
Thank you, ma'am, for your inspiring words. Now I request Dr. Madhuchanda Patnaik, Head of the Department of Physiology, Keonjhar, to felicitate ma'am with a memento.
A very good morning to all of you, respected dignitaries on the dais and off the dais. I have come here actually for Arpita and Madam, Principal Madam, because I know the academic activity done by Arpita is always well appreciated and is excellent. In several occasions, starting from our PG days, we are going on attending her arrangements, starting from food to academics to photography. Everything becomes very good. So looking forward to attend such a nice conference and symposium. Thank you.
Now, I would invite on stage our guest of honor, Dr. P. Sarachandra, neurosurgeon, AIMS, New Delhi, to speak a few words.
Honorable faculty on dais, Dr. Arpita, heartiest congratulations on being able to organize this very interesting and very nice and very important and very relevant topic as of today. I think much of this will be spoken about in the symposium which will be held till 5 p.m. So I won't like to speak too much except for expressing my gratitude for giving me an opportunity to be here. This is my home state. And it always gives me a great sense of, closure whenever I come to my home state, because I was born in Cuttack, I did my MBBS from Berhampur, and then of course we've been staying in Delhi for the past 25 years, 26 years. But I would like to point out that sleep was never an unimportant thing in our Odisha culture. So we have, for some reason, it's in our genetics, it's in our tradition, to give adequate importance to sleep. And unfortunately, when the modern civilization caught up, this became a matter of criticism. So sleep was always equated to laziness. Of course, to some extent, if you sleep too much, it is laziness. But I think the modern medicine has greatly neglected sleep, and sleep has been the biggest victim of the modern civilization. And it is something which people thought could be very easily disposed of. For instance, when I did my neurosurgical residency, I had, a big culture shock when I started training, because MBBS was so relaxed. You had your 7-8 hours of sleep, and then suddenly in neurosurgery, where you lose to sleep regularly for 2 days a week. So for 2 days a week, you're not sleeping. So that's how I trained. For 6 years, for 2 days a week, I would not sleep. And it was terrible at this instant. And if you ask any of the persons, any of the residents who has done the neurosurgical residency, either from AIMS or from NIMHANS or from PGH Chandigarh, they'll say, what is that which was toughest? So they will say, number one, missing sleep and doing some emergencies at 4 a.m. and 2 a.m. in the morning. And number two is lack of food. And I totally agree with them. You miss. I remember, we would go for emergencies at 2 a.m. in the night, in the morning. And you start some contusion, some extradural, and it'll go, you feel terrible. You say, okay, let me just have a few minutes of sleep, I'll be so happy. And then you're feeling hungry. So I think overall, sleep is something which has been grossly neglected. And over the past 2 decades, the importance of sleeping is becoming very, very important. There was a saying, when I was doing my MBBS, there used to be a saying. People used to say it, even though with little bit of humor. And I will gently ask Dr. Arpita if this could become the tagline of our meeting. So people used to say, when they go and waste their time in some occasion or some issue, they will say, what is this? Kahin kasuliyati? Ame soile labothila. So I think you should add the tagline, there is profit in sleep. Soile labhochi. So perhaps the tagline of a conference should be that there is profit in sleep, which we realize more and more that it is absolutely nothing illogical. So with these few words, I will end my talk here, because there are a lot of things to be spoken about. And once again, I congratulate Dr. Arpita for having organized this beautiful symposium, and I humbly give my prostrations to the seniors sitting on the dais, and once again thank for this opportunity to be here.
Thank you, sir. Now I'd request Professor Dr. Sharmistha Swain, Head of the Department of Biochemistry, to felicitate sir with the memento. Thank you, ma'am. Now I request Dr. Baidyanath Mishra, Assistant Professor, Department of Physiology, to express the vote of thanks.
Good morning, everyone. Respected Dean Ma'am and respected dignitary on desk. I started here on behalf of Sleepwell Odisha as a proud and grateful to express my heartfelt thanks to all those who have made this event possible. I would like to start by thanking our head of the institution, Dean and Principal Ma'am, Professor Dr. Maya Padhi Ma'am, who have always been supportive of our initiative and encourage us to strive for excellence. Thank you, Ma'am. Thank you, guest of honor and chief guest. Very excellent, enlightened words. Then, initiation is the root of organizations. So all are initiated, registered, and participate. So now this event going to very successful. That's why thanks to our all delegates. Thank you all eminent speakers here, and thank to technical part, technical support, because I am here offline and online mode also available. Many participants join also online modes. Thank you technical support. And one last time, I would like to express my appreciation to everyone who work on this event. Our department, physiology department, all staff members, and especially dear PPG students. Yeah. Very nicely arrangement. Thanks to all dear PPG students. This is the formal end part of the inauguration session, but end is not the meaning of end. End means effort never dies. But this event just start, just the beginning. After tea break, our scientific session will start. So all are present here. I am especially a thanks to all participants, those who are encouraged our Sleepwell Odisha. Especially thanks to our head of the department, Professor Dr. Arpita Pirasniman, who is the Vishwakarma of this Sleepwell. So, lastly, thanks to all, and Jai Jagannath.
Thank you, sir. Now we have a tea break for 10 minutes.
Welcome back. Now I would like to request Professor Dr. Madhuchanda ma'am, Department of Physiology, and Professor Dr. Arati ma'am, Department of Pediatric, as chairman of this scientific session. Next, I would like to request Professor Dr. Arpita ma'am to enlighten us with her knowledge regarding must know about the sleep and the sleep disorder.
Good afternoon, everybody. Respected our chief guest, Madam Indira Madam, and our ex-DM sir, our dean and principal, my senior professors, and all fellow delegates. Dr. Arpita, I think, need no introduction, and she will speak on.
I will speak on
the beginning of the sleep. So I invite Dr. Arpita to start the session.
Thank you so much, Madam. With the blessing of Ma Saraswati and my seniors here, I stand before you to be the first speaker of this wonderful scientific session. And the topic is very close to us, and the beginning of health is sleep. This is an Irish proverb. But 1,000 years back, someone said something much more than what people then could think of when Aristotle, Greeks, and Egyptians were thinking that sleep is initiated at the heart level. Charak was thinking of what sleep is doing to us, and it's still relevant in these days. Nindriyatam sukham dukham. Prishti karya valavalam. Vrishata, klivata, jnanam ajnana, jivitam nachaha. Happiness, misery, nourishment, emaciation, strength, weakness, virility, sterility, knowledge, ignorance, life and death, all these occur depending on the proper or improper sleep. That was the observation then. So understanding sleep, to the topic proper as a basic course, all of us know, but we really cannot define. So how do we define sleep? How do we in fact diagnose sleep? Everyone is asleep. Everyone who is asleep taking a snore is not sleeping actually. So how do we diagnose sleep? Sleep is a period of reduced activity. It has a typical posture. You can see everyone has a typical posture during sleep. And there is a decreased responsiveness to external stimuli. This is very peculiar. How can we just disconnect from this world immediately we sleep? How it happens? And sleep is a state that is relatively easy to reverse, and it distinguishes sleep from other state of reduced consciousness, that is hibernation and coma. So looking at this, sleep is universal. Everyone sleeps, including the plants and the animals. But still, the purpose of sleep is elusive. As we can see here, that all of them have typical features of sleep, that is quiescence, posture, lessens responsiveness, can rapidly wake up from that state. Immediately you call, the person wakes up. And whenever you have sleep deprivation, you sleep more. And that you have to make up for your sleep loss. And it is affected by sleep drugs. And it has a circadian regulation. And there is changes in brain and cellular activity. And this happens, and sleep is conserved at the gene level. So these are very peculiar things which is relevant to all animals and plants. So what are the theories of sleep? Why do we sleep? What is the theories of sleep? The first is that it's a restorative function. The growth hormone, which is increased during sleep, there is tissue repair and protein synthesis. There is energy conservation, all of us must be knowing, during infancy for brain development. No sleep during infancy, there cannot be brain development. Memory consolidation, whatever you are learning, it is memory, you are getting, you can remember it, you can recall it. It is not because you are great, it is because you have sleep as the most important cause of your memory. Then synaptic homeostasis, the brain plasticity, I mean, it's not rigid. The change, you accommodate to life, the changes you are facing and the changes you are flexible, it's all related to the synaptic homeostasis, and that's basically by sleep. And the 2012, this is a very important discovery. 2012, the glymphatic system came into view, and it's a sewage cleaning or a cleaning system of the brain. It is said during sleep, 60% neuronal size decreases. As a result, cleaning can occur through these paralymphatics. And this cleaning cleans all your toxins, your beta amyloid proteins, which causes your Alzheimer's, your glutamate. It cleans. It's like a dishwasher cleaning during sleep. So when you're sleeping, you're being cleaned of your toxins, the glutamate, the extra toxins, those which you don't need. So this is also a theory to sleep. Historical landmark. Again, Charak said, in the consciousness, you have four level of consciousness. A waking state, that's Jagrata. A dream state, the robust Zeitgeber, which maintains our biological clock, that is suprachiasmatic nucleus. So our people knew about sleep regulation is possible only when you observe sun. So that is what I wanted to show you. Then they knew about this, the Zeitgeber, the importance of sun as the most important factor which regulates a biological clock. So now coming to English, Western science, the first definition in 1834 came by the philosophy of sleep by Robert. Sleep is the intermediate state between a wakefulness and death. Wakefulness being regarded as the active state of all the animals, and intellectual function, and death is that of total suspension. What I want to show you, 1,000 years back we knew sleep. In 1834 it is being written, documented in science. So coming to this, very important, the Saptarishi, like you have Saptarshi Mandala, the 7 people who made sleep so relevant and evidence-based medicine, and so that we can practice it. It never happened like that. It was non-existent. In 1875, someone found out electrical rhythms are possible, and that in the brains electrical rhythms are happening. In 1928, it was recorded by Hans Berger, the electrical rhythm of the brain. And this Legendre and Piron, the French physiologists, they found out that there are certain chemicals. So there was a neuronal theory and a chemical theory which is responsible for sleep. In 1930 and 36, Friedrich Bremer, sleep as a reduction activity, sleep is a passive state, and reduction of sensory input causes sleep, was the passive theory was given by Bremer. So he was the second Rishi. Then by 1937, 1939, the brain activity, the electrical activity was well noted and well classified in Harvard University and Chicago. Then after World War II, 2 more scientists came up, that is Horace Bagow and Maruzzi, who said that because of the reticular activating system, there is a waking state and that of sleep. 1951, REM sleep came into action, when Nathaniel Klitman and Eugen Asarowski said about the REM and the dream state. And Sigmund Freud, the psychologist, the psychoanalyst, he said dream is like a safety valve of the mind. It's like a pressure cooker. When you are so very pressurized, you have a safety valve which takes out the pressure. Same also the dream works like that. The first neuroscience bestseller was written in 1954. And Michael Jovett, who found out where this REM starts from in the Pons area. And he talked about the paradoxical sleep and the paralysis during the REM sleep, and also about positive forgetting during the REM sleep. That's very interesting. You forget many things so that you can accommodate new things. So forgetting is so important, and REM helps you for your positive forgetting. During REM, Not only you consolidate, but you forget many things so that you can accommodate. So all night sleep recording is done all night. It was done by Nathaniel Kleitman and William C. Dement in Harvard. 126 nights on 33 subjects it did. And by that, they found out, they studied that, and by 1974, they had a full-fledged sleep lab. And 1970, Stanford was the sleep hub. In 1972, earlier polysomnography meant EEG, EOG, and EMG. But it is Christian Guilleminault who added some more, that is the respiratory and cardiac sensors, to make it more clinically evident. 1974, Jerome Holland termed the whole thing as polysomnography. So this is a small tribute to these great rishis whom I call, and you can see that Nathaniel Kleitman in June 1, he became 100 and he lived through 100. So these are the 4 great scientists having a gala time talking about sleep. So now come to a very interesting fact. You can see the sleeping hours, as you see, in the Victorian age, it was biphasic. No one slept throughout the night. Because there was no electricity, they slept at, says, the moment it was dark, they slept off. They got up around 12 to 1, they did some house chores, then again they slept. It was biphasic. And slowly, as electricity developed, in the Edwardian time, they had a continuous sleep. And modern time, when refrigerators, small electrical gadgets developed so that handmade things, they didn't have to work manually, they had a better sleep. Then what happened in World War II? During World War II, they were so afraid. They were so afraid that they could not sleep. The sleep was totally deranged. They had fragmented sleep. Then come to the modern time where mattresses, what we see here, the mattresses we sleep on was not there during that period. So the mattresses, the air conditioners and everything came up. The gadgets, slowly, modern era changed the sleeping scales. And in COVID, you saw what happened because of the modern time. So, in Gita it is said, O Arjuna, yoga is not for one who eats too much, or not at all, for one who sleeps or keeps awake in excess. So yoga is conscious evolution, perfection, discrimination, highest consciousness. So that level will never come if you eat too much or sleep too less. So that is what is written in modern science. Sleeping less than 6.5 hours, more than 9 hours is associated with 1.7 times mortality. So what is the determinant of sleep? How do we sleep? It happens just like that? No. You have 2 important drives. One is your homeostatic or cellular or metabolism drive. As you live through your life, every day, you produce a metabolite known as adenosine. And with time, as you're awake and you produce adenosine, it goes up and up. At that level where adenosine is very high, you feel that it creates a sleep pressure. It doesn't happen like that. So at the metabolic level, adenosine has to increase. And at the circadian level, melatonin has to increase. So these 2 important homeostatic factor and the circadian factor is the determinant of sleep. So you have a sleep and wakefulness. There are 2 parts in your hypothalamus which is very important. As you see, you have a sleep promoting system which is in the hypothalamus. You have only one area which promotes sleep and many areas for keeping you awake. One area, ventrolateral preoptic nucleus, and which produces an inhibitor GABA and galanine, which is inhibitory to the cerebral cortex. And in the brainstem and thalamus and hypothalamus, you have arousing system which has plethora of neurotransmitters. They help you to be awake. So one neurotransmitter can make you sleep, but you need many neurotransmitters to keep you awake. So if you are awake for a long time, you are depleting your neurotransmitters. Be careful. Only when you sleep, then only you can be perfect when you are awake. Because during sleep, you conserve these neurotransmitters which help you to keep you alert and awake and successful. So this is a sleep-wake switch. So once you are sleeping, like our switch, if it is on, it is on. If it is off, it is off. There is no in-between points. So when you are awake, that is your on. When your switch is on, you are awake. And when your switch is off, you sleep. So this ventrolateral preoptic area is your switch off area. When it is stimulated and it is controlled by melatonin, and it is rather, I would say, not controlled, but rather it helps and facilitates the center to induce sleep. And wake happens, or the switch on area happens when all these hormones, which is stabilized by orexin, helps you to stabilize all these hormones to keep you awake, sustain wakefulness. Do you think, why do you feel sleepy here sometimes? You can't sustain wakefulness. It is all the play of neurotransmitters. Your nucleus is important for switch on and switch off of the sleep mechanism. So at the micro level regulation of sleep and awake, wake promoting neurotransmitters are many. Acetylcholine, dopamine, glutamate, histamine, norepinephrine, orexin, serotonin. And all of us know, basically during our pujas and during upavasa and when we take fruits, it consists of all those are wake promoting, like a banana, contains a lot of serotonin. And all this, as you see, your wake promotion, and you see all the food related to upavasa and whatever vidhis we have, it improves your wakefulness when you're taking those kind of light food which will help you awake. In non-rapid eye movement promoting are adenosine, GABA, galanin, and melatonin, your sleep. And REM promoting, as you know, REM is a paradoxical sleep. It contains some element of the wake promoting neurotransmitters like acetylcholine and glutamate. So it is in between state. It contains the neurotransmitter of wake state and also the neurotransmitter of the NREM or the sleep state. So we can manipulate. So there are so many sleep promoting drugs and wake promoting drugs. So they are all working at this level of these neurotransmitters through receptors. So we can change your sleep patterns through drugs also because we have so many neurotransmitters. So it's a ballet. Sleep is a ballet. It's a dance. You have 5 stages. You have stage 1. When you sleep, it doesn't happen that you're sleeping and it is all same throughout the night. No. There's a lot of dances happening because of the movement of these neurotransmitters, creating so many brain activity which can be recorded by polysomnography. So according to the polysomnography, by hypnograms, by EEG, EOG, and EMG, we have 5 stages: NREM and REM. NREM has got stages, and REM is one of them. And stages 1, NREM, it's a light sleep. NREM stage 2, sleep onset. Stage 3 is deep sleep, and REM is very interesting. In that state, you think you are sleeping, you are dreaming, all skeletal muscles are paralyzed except your diaphragm, your ocular muscles, and your hearing muscle. Because they are not paralyzed, you are able to, someone can wake you up. So all this happens as a result of which you enjoy sleep, and sleep is recommended according to the age. But as we are all adult, we need minimum 7 to 8 hours of sleep. And as we see here, as we grow, it's like the Mahanadi is now trickling down to a stream. Same also as we start with REM. When we are a newborn, we are a neonate, we have lot of REM sleep in us. Why? REM sleep is very important for learning and memory consolidation. That is why small children, small neonates, they have lot of REM sleep, as a result of which they can learn more. And learning is very important, and REM sleep can be sustained in your life if you know how to learn newer skills. So the moment you learn newer skills, REM sleep develop. So as we grow, we lose REM, non-REM, and we become homeostanosed, and we have sleep failures with age. And how many sleep cycles you need per night? As you see, this is a hypnogram. This is a polysomnography, where depending on the brain activity, depending on the electrical activity, the staging is done. That will be shown, and the second speaker is going to speak on polysomnography. So as we go into the different stages, after we enter 4, then slowly we come back to REM. So from the stage 1, the whole NREM and the end of the REM, that makes 1 cycle. So such cycles are minimum 4 to 5 you need, provided you sleep continuously. we have lost our ability to sleep continuously for more than 6.5 hours, and that is sleep failure. Like you have heart failure, joint failure, this is sleep failure, not able to sustain, having a sustained sleep. And we must have 4 to 5 such cycles of non-REM and REM, which is within, say, 90 to 110 minutes. Each cycle takes 90 to 110 minutes and then repeats. And as you see here, as you go throughout, when the dawn comes, your REM lengthens. Many a times you must have seen that many people will be calling you, but you can't get up. It's not because you can't get up, because you are paralyzed. All your skeletal muscles are paralyzed in REM. And REM is so important for almost all nuisance activity, your death, your respiratory changes, your arrhythmias, your epilepsy. REM is so important. So there is a lot of difference between, all this can be taken back. I will not go into detail. So what I can show you here is that, so in the REM, the muscle tone decreases. In the wake state, as you see, the heart rate and blood pressures are variable, but in non-REM it is slow, low, and regular. There is a dip in all your physiological parameters when you have a deep sleep of non-REM. And once you have 20% of your sleep is a deep sleep, you will never be addicted to anything. You don't have any interest in addiction if you have good 20% of deep stage 3 sleep. If you are anyway addicted to anything, it shows that you don't have good sleep. So addiction shows a sleep failure. I will not go into detail of this. This is how a polysomnography, a sleep lab looks, and this is how a sleep study is done. And this is a hypnogram that will be taught. Now give sleep a voice. Time has come, sleep has to be discussed. Because so much of lighting throughout the night, Thomas Alva Edison did not know that you would be the cause of all complications in our life, making our night into day. And to end with it, the mobiles and the gadgets we are using full of blue lights, it is changing our pattern, our physiology, and maybe we will be a different kind of human beings, something different because of this, how the world sleeps. It was earlier 8.4 hours, now it is 6 hours. We have started cheating on sleep too, and we have to pay for this cheating. And what they speak about, that 80% of world population wants to improve upon sleep. Can you think what is the market? Few billions are being, a few billions are being used just to make people feel to improve upon sleep. And 67% of people in the world getting up at least once during night. And 63% sleeps longer in the weekend to catch up sleep. And 49% just say, I'm getting enough sleep. And 10% of the world population can say, I'm sleeping extremely well. So, coming to the last part of my talk, which you will never read, but I just want that you should know, there is a classification of sleep disorder. The first classification of sleep disorder was in 1990, the first edition, this book came. The second book came in 2005. And this third edition, International Classification of Sleep Disorder, is in 2014. And here I present you only the index. You must know. The first group of disorder, we have 88 varieties of sleep disorders. 88 varieties of sleep disorder, treatable. As you know, sleep is the window for your mental health, physical, social, your economical, everything, because all of us know a beautiful sentence written in the Lancet is that sleep is for the brain, by the brain, and of the brain. So like you have a prostate marker, you have a pap smear for a uterine marker, or so also, sleep is the brain marker. If you are functioning, your brain is proper, sleep is the marker of that. So what are the disorders that could be possible? So it has been seen, the first disorder which is classified is insomnia. We have varieties of insomnia, 10% are insomnics. Odisha, we don't have data. Second group is sleep-related breathing disorder, and you know all about snoring. It's in rampant because we have all become Occidental. We are eating a lot. We have a lot of food. We will eat and we will grow in both. We cannot grow in length. We will grow in girth, as a result of which we'll choke ourselves and will die in ICU. And we are very, very fine with it, and we are ready for ICU than to have a proper height-weight management. And worldwide data is that obstructive sleep apnea is 6.62% in India. Because of the paramparas, we have so many upavasa. Because of that, you go to a village, compared to that, whoever believes these, not question of belief, whoever maintains it, has so many ways of not taking food in so many days that helps. That is why all this was done, to keep our weight and height under control so that we don't enter into any complications. The third group is central disorder, hypersomnolence, and narcolepsy is so common. We never knew that narcolepsy was there, sleep paralysis. You will be walking, you'll be talking, and you don't have control over your sleep urgency. You will just paralyze and you will sleep. Then and there you will sleep. And worldwide it is 0.02, and in India it is less than the world. The fourth group, as you can see, is circadian rhythms. You're playing with the circadian rhythm. You're playing with the biology. You're playing with the sunrise and the sunset, as a result of which we have so many problems. And common problems are delayed sleep. Most of us sleep beyond 12, many sleep by 6, so advanced phase disorder, so many things, your jet lags, your shift working, they have tremendous bad effect on us, and worldwide it is 3%, India not known. Then we have sleep-related movement disorder, your restless syndrome, your periodic lift movement, and so many things happen during sleep, and you do a lot of movement. So the data are not known, but they are there. And this is all about, I just wanted that you should know about sleep disorders, and these are also part of the sleep disorder. So the paradox of the sleep is that it's not a same thing. In your sleeping brain, in one part it conserves energy, restores plasticity, protein synthesis, memory consolidation. In another front, adverse respiratory environment, your asthma attacks. Unfavorable cardiovascular environment happens during sleep, and many of us die in the early morning. So it is seen in our ancient thought, those who die in the Uttarayana in the morning, they had a good life. Those who die in the night, they never had a good lifestyle. So be careful when you die. Your time of death speaks about your lifestyle. You need not speak about your lifestyle. So danger you have is GI systems. Reflux. All the acid reflux are during GI. All these are possible during sleep. Your motor discontrol, sleep violence, they're all possible during sleep. So don't take sleep so casually. Sleep will heal. Short periods of sleep loss at the time of vaccination reduced vaccine's effectiveness. Sleep loss is associated with obesity. Obesity is not because you're eating more, eating less, it is because you're not sleeping. Sleep loss is also associated with diabetes and impaired glucose tolerance in a dose-related manner. Individuals that report sleeping less than 6 hours per night, 1.7 times likely, and those that report sleeping less than 5 hours per night are 2.5 times as likely to have diabetes than individuals that opt in 7 hours of sleep. So cardiovascular disease and hypertension are also very highly associated. The risk of a fatal heart attack increases 45% in individuals who chronically sleep 5 hours per night or less. I have seen great doctors who have always said, Arpita, we work so much, we don't have any problem. But the day they say, by within 15 days, I hear they had a heart attack. So be careful. If you're not sleeping, chance of heart problem would be very high. So last part of it, 8 practices for good sleep. Set a regular sleep schedule, don't change it. If you sleep at 10, every day sleep at 10. Create a relaxing environment, make it dark. Don't use any red, yellow, blue, brown bulbs in your bedroom, because caterpillars, when they grow into butterfly, they happen in cocoon in deep darkness. In depth of darkness, there are a lot of colors compared to all these colors around. Understand your sleep patterns. Exercise, not before your bedtime. Disconnect. Put work aside. Watch alcohol and caffeine intake. Caffeine is very activating. Once you take caffeine and sugar nearer towards your sleep time, you will remember your past, future, and you start complaining about your life. Honor your circadian rhythm too. And last slide, which is very important, from the Bible, which says God gives his beloved sleep. If you are God's beloved, you will get sleep. Thank you so much. Thanks a lot.
Thank you, Professor Arpita Priyadarshini, for the enlightening speech. You spoke so much about the physiology of speech, physiology of sleep, and how we can keep ourselves healthy by maintaining a pattern, general pattern of sleep, not sleeping less than 6 to 7 hours per day. Thank you.
Thank you so much. Next. Thank you so much.
Thank you, madam, for this enlightened topic. We as a doctors should take sleep history in our OPD. So how and why we should take, because the sleep is so much important that we should take sleep history in our OPD. So for this, I would like to request Dr. Sorin Gunia, sir, Department of Pulmonary Medicine, AIMS Bhubaneswar, regarding this topic, sleep evaluation in OPD and sleep lab, a necessity. Sir, please.
Good afternoon, everyone, and thank you very much for that kind introduction. At the outset, I would like to congratulate Arpita Madam for taking this initiative and organizing this beautiful basic workshop on sleep. And my sincere thanks to Madam for remembering me and inviting me to be a part of this basic sleep course. My topic is how to evaluate sleep disorders. The outline would be, I will just quickly give you some case scenarios where we will understand what is the spectrum of, what are the spectrum of sleep disorders that we come across in our clinical practice. And as Madam has beautifully given us an overview of the sleep disorders, the physiology, and in one of the slides, I remember Madam was comparing the prevalence of sleep disorders among the Western countries and India. So it was around 6 something% in the Western countries, but some studies have even shown to be as in the Western countries. But in India, it's less, but I think it's mostly remaining undiagnosed because of the epidemic of obesity that is going through in our country, and because of gradual more and more adoption of the Western lifestyle, the changes in the lifestyle that is taking place in the newer generations. So this obesity epidemic is causing a lot of sleep disorders, and I think we should be very vigilant whenever we come across any patients, and we have to include the sleep history in our clinical practice. And I'm going to discuss that. So these are my disclosures. So quickly, let me give you one case scenario. So this patient came to our sleep clinic. So this gentleman is a 45-year-old male lawyer who presented with chronic fatigue and exhaustion. He's telling that I am feeling tired the entire day. There's a feeling of exhaustion, and that's for a long period. And his wife is telling that he becomes more tired when he comes to home from the work. He's having trouble concentrating on his work. And in the evening when he comes back home, he usually dozes off in front of the television while waiting for dinner. And sleep also is not having a peaceful sleep. He is 38.4. And he also described as his feeling of embarrassment frequently, as he occasionally falls asleep during important meetings. So, upon the medical history, we found that he was recently diagnosed to have type 2 diabetes and also hyperlipidemia. The social history, he was intensely focused on his career with no time for any other personal hobbies or pursuits. And he did not have any addiction for smoking or alcohol, but he used to drink 10 to 12 cups of coffee every day to keep himself awake throughout the day. So when we reviewed his sleep pattern, we found that he had a normal sleep schedule. He used to go to bed by say around 12 midnight, and he used to wake up by 7 a.m. And according to him, he has been sleeping very soundly. and he wakes up 2 to 3 times in between, in the middle of the night, to go to the toilet, and occasionally awakens during the night gasping for air. He has a choking sensation. He wakes up in the middle of the night, and in the morning when he wakes up, he doesn't feel fresh, with a heaviness in the head. So the overall, whatever we took the history, he has got a classical history of obstructive sleep apnea. Means then we did a polysomnography. Then he was confirmed to be having obstructive sleep apnea with a very severe category, with hypopnea index of 54, and with frequent oxygen desaturations. Oxygen was falling to low 80s during his sleep. So this was one case scenario. Now let's come to another case scenario. Here, this lady was a 40-year-old school teacher, and he complains of inability to sleep well for over 2 years. She is complaining that she is not having adequate sleep. She is not having adequate sleep. She goes regularly to bed at 10 p.m. but is unable to sleep till 1 a.m. She has been lying on the bed, but she cannot fall asleep. After about 3 hours, she gets to sleep. Then she experiences about 3 to 5 awakings every night, and with each awakening requires about 30 minutes to fall back to sleep again. So whenever she gets up, she cannot fall back to sleep again. It requires around 30 minutes before she again sleeps. So she experiences daytime fatigue and is unable to concentrate on her work. So in the previous case also, there was fatigue and inability to concentrate on the work, and here also she cannot concentrate on her work. So does not take daytime naps, does not snore, and no limb movements during sleep. And as the bedtime approaches, she becomes very tense and worries about the prospect of another sleepless night. She becomes very tense that today also I might not be able to sleep again. So every night she is telling, every night when I lie in bed, I have to try very, very hard to sleep. I keep watching at the clock. So this is how she spends her night in the bed. So she was diagnosed to be having physiological or behavioral insomnia. So these are two ends of the spectrum. So on one hand, we have got a patient who is sleepy all the time. He is feeling sleepy all the time. And on the other end of the spectrum, we have someone who is not having adequate sleep at all. So just to give an example, so this could be the spectrum of sleep disorders which we come across in our clinical practice. And besides this, we also come across many, as Madam has already shown, we can come across patients with the circadian rhythm disorder, the advanced or delayed the sleep cycle. And also we can come across patients with parasomnias, where there is abnormal movements or behaviors during the sleep. So these, in a nutshell, these are the spectrum of sleep disorders which we come across in our clinical practice. So sleep disorders are very common, and the prevalence increases with age. And there are a few very common misconceptions among the general public that sleep disorders increases a normal and expected phenomenon of aging. So they tend to ignore the fact that there is a sleep disorder, and though they do not seek the medical help for any sleep related problems. And also another misconception is that snoring during sleep indicates a peaceful sound sleep. So whenever the general public, they tell that yes, he is sleeping very soundly, has been snoring throughout the night. So that's a misconception actually. So that awareness should be there among the clinicians first, and then among the public, so that whenever we come across any patient telling us that we snore during sleep, then we should be very vigilant. We should evaluate to look for any obstructive sleep apnea. Sleep disruption is often due to medical and psychosocial comorbidities and the use of multiple medications rather than age per se. So these things we have to be aware of these things, that are there any medical conditions which is causing the sleep disorders in such patients. A major concern is the strong bidirectional relationship between sleep disorders and medical comorbidities. So there is a bidirectional relationship. So hypertension, diabetes, cardiovascular diseases and stroke are more likely to develop in people with sleep disorders. Conversely, individuals with these diseases have higher risk for developing sleep disorders. So there is a bidirectional pathway. Many clinicians are unaware of the potential morbidity associated with sleep disorders in the elderly. So sleep disorders can have significant negative effect not only on the quality of life but also on the morbidity and mortality. As Madam has already told us, that there is a high incidence of sudden cardiac death, the stroke, ischemic heart disease in persons who are not having adequate sleep. So now how to evaluate these patients in our OPD? So going to the basics, it's only history, and history. So if we take a good meticulous history, we can diagnose most of the sleep disorders, and we need the help of lab only just to confirm our diagnosis and that will help us in the management. So regarding the detailed sleep history, first we should know regarding the sleep timings. So what do we ask the patient? So how many hours do you generally sleep? So we should first know how the patient has been sleeping during his day-to-day life. Is he getting adequate sleep or not? So how many hours does it take for you to feel well rested? Means after how many hours of sleep the patient feels better, fresh the next day. So there are short sleepers as well as long sleepers. I personally feel I'm a short sleeper because I feel refreshed the next morning, even if I get around 5 hours of sleep. But let me tell you, my wife, she is a long sleeper. She is not satisfied with 5. She tends to sleep for 8 to 10 hours. Then only she feels. So it's a subjective thing. It varies from person to person. So do you take daytime naps, and for how long? So we should understand whether the patient is also sleeping during the daytime. So that might affect the nighttime sleep. Then we should ask about the normal sleeping habits of the patient. What time do you go to bed and get out of bed on a normal day? The usual sleeping time. When do you go to bed and when do you wake up? What is the time required for you to fall asleep once you go to bed? Do you immediately fall asleep, or does it take time for you to fall asleep? So usually it's called the latency period, the sleep latency, when we go to bed and the time we fall asleep. Usually normally the sleep latency should be around 10 to 20 minutes. We should fall asleep within 10 to 20 minutes. If it is less than 10, then also it is then there is a pathologically the person must be highly sleepy, or if it is more than 20, then also it might indicate that insomnia. So do you wake up in the middle of the night, and if yes, how many times, and what is it that wakes you up? So we have to ask whether the patient is having a undisturbed sleep throughout the night, or he or she wakes up frequently, and what is it? Is it because of the urge to go to the toilet that he wakes that person up, or something else, any choking sensation or anything, any sensation in the limbs, any movement, that we have to ask. How quickly are you able to get back to sleep? So once you wake up in the middle of the night, do you get back to sleep immediately, or it takes some time? Then we also need to have some idea regarding the quality of sleep. So what do we ask? Do you feel refreshed in the morning? So if the sleep quality is good, then only the person will feel refreshed and raring to go the next day morning. So how long does it take for you to feel refreshed after awakening? During the day, are you chronically fatigued, sleepy, or tired? So that will give us the idea about the quality of sleep that person has had the previous night. Now, very important, the history of snoring. So do you think you snore at night? Most of the snorers will deny that, yes, I never snore. Because, so this history has to be taken, usually the sleep history. Whenever we take a sleep history, we always ask the person to come with their bed partners. So they will be able to better give you the sleep history. So then are your snores heard outside the room? Do you snore very loudly so that your snores could be heard outside the room, from the adjacent room also? Do you think your snoring is worse while lying on the back or on the either side? So people tend to snore more because of the physiological position. When we lie supine, the snoring tends to be more louder, and if we lie down on the side, there might be some decrease in the degree of snoring. Alcohol, so this history is very important. Usually the persons tend to take alcohol in the evening, and on those days particularly the snoring and the sleep disorder breathing is worse than the other days. Because of the effect of alcohol. Alcohol usually relaxes the airway muscles, and the airway collapsibility increases on the day on which they take the alcohol. Then we have to ask about the apneic events. Has your bed partner ever noticed that you transiently stop breathing while asleep? Have you ever felt or observed that while you sleep there is a silent period with no snoring followed by a loud snort or a body jerk that awakens you? Means the bed partner might have observed that the person must be snoring continuously throughout the night. Suddenly there is a calmness, there is a total silence. That means the patient has gone into cessation of breathing. So there is no snoring at all. Then again suddenly he wakes up with a like this, he wakes up and then again he resumes the breathing. So this is a very scary kind of sight which the bed partner observes in case of severe obstructive sleep apnea. Have you ever experienced episodes of choking or waking up in the night short of breath? Do you ever wake up in the middle of the night with a choking sensation of airway collapsibility? This history is often elicited by the bed partners. Now again we have to take the history about the abnormal behavior during the sleep. Do you have any urge to move your limbs in the early part of the night? The periodic limb movements which can disturb the sleep of the restless leg syndrome. There are some disorders of the movement disorders which can affect the sleep at night. Has anyone noticed any abnormal movements behavior during sleep at night? There can be sleep talking, sleep walking. So all kinds of abnormal behavior are possible. There can be REM related sleep disorders. And also we have to ask about the daytime functioning so that we can have idea about the previous night sleep. Do you wake up in the morning with a headache or heaviness in the head? Usually those who have severe obstructive sleep apnea, they wake up with a heaviness in the head because of the chronic hypoxia which has been taking place throughout the night because of the desaturations. Have you felt that you are mostly tired or fatigued during the day? Have you ever dozed off in the meeting or while driving? This is a very dangerous thing. We have come across so many patients who complain that they have nearly missed some accidents or they have already gone through some accidents because they have dozed off while driving. So this is a most common cause of road traffic accidents, the obstructive sleep apnea. So we have to be very careful in taking this history. And also about the personal habits, any history of alcohol consumption. If there is history of alcohol consumption, there's how frequently do they consume alcohol. Also tobacco consumption, because even smoking causes the airway inflammation and can narrow the airways, which can aggravate the symptoms of sleep disorder breathing. And the habit of consuming tea and coffee or caffeinated drinks, which affects the sleep. So again, after this history, then we have to take a detailed medical history. What comorbidities the person is suffering from, the heart diseases, is there any arrhythmias, the heart failure, the hypertension. So the sleep disorder breathing is a very common cause for resistant hypertension. Patient might be having, patient might be on double or triple antihypertensive, but still the blood pressure is not getting controlled. So there might be underlying obstructive sleep apnea, which might be the culprit for the resistant hypertension. Thyroid problems, hypothyroid is a common association. Diabetes mellitus, stroke, epilepsy, headaches, we have to take the history. Asthma, COPD, sinusitis, many times patients of bronchial asthma, also they have this nighttime worsening because of because of the circadian rhythm, because of their bronchospasm in the middle of the night. There might be overlap also. Patients with allergic rhinitis, nasal congestions, they have more aggravated symptoms of this sleep disorder breathing. So deviated nasal septum and enlarged tonsils and allergies, depression, anxiety, bipolar disorder. So we have to take a detailed history regarding the associated medical history. Cardiovascular disease, cerebrovascular disease, metabolic syndrome, gastroesophageal reflux, and obesity. So, and also a detailed drug history is required. Any medications need to be noted, because usually patients of insomnia, they tend to have give a history of a long history of taking benzodiazepines. That is a very dangerous thing. They become dependent on benzodiazepines, and benzodiazepines they affect the quality of sleep. They alter the state. The deep sleep is usually affected, the N3 stage is reduced, and also the REM sleep. So we have to take a detailed medical history, the drug history. So also the occupation history is very important. What is the job? If the patient requires to be alert during the daytime, the drivers or pilots do have job involves a lot of stress. The work time, is it a 9 to 5 job, or the job involves shift works? Social history, general quality of life should be evaluated. General attitude of the patient, his family and colleagues, whether the family members, they are supportive or not, that will help a lot in the diagnosis and management of the patients. Now, after we have taken a detailed history, we have noted down our points, positive points, then we come to the physical examination. So we will be able to come to our diagnosis of sleep disorder mostly by the history, then we do a physical examination. Among the physical examination, BMI is the basic thing. We need to have the weight of the patient, the height of the patient, and also neck circumference, the waist circumference, waist to hip ratio, which gives an idea about the central obesity. The neck circumference, if it is more than 40 centimeter, then they are more prone to develop sleep disorder breathing. Whether the patient is having enlarged tonsils or not, that compromises the upper airway caliber. Elongated soft palate, large tongue, high arched palate, large uvula. Then we do the Malampati grading. There is a Malampati grading. I will be showing you the pictures, grade 1 to grade 4, where which will give an idea about the airway opening. Then we have some facial deformities, some facial abnormalities like retrognathia and micrognathia. They are more likely to have this sleep disorder breathing. So this is how this is a case of retrognathia. You can see. So this is the size of the mandible is normal, but it is more posteriorly placed. So that will compromise the airway. So this is an example of micrognathia. The size of the mandible is small and it is also posteriorly placed. So such patients are more likely to have sleep disorder breathing. Then this is an example of very large tongue, so they tend to fall back when we sleep, and there will be obstructive sleep apnea. They contribute to obstructive sleep apnea. And also these are enlarged tonsils. So when we have such big tonsils, usually in children they are large adenoids, they are the cause of obstructive sleep apnea. So this is the Malampati grading. So here we have, when we have to observe the oral cavity when we examine the patient. So here we have the uvula, the pillar, the soft palate and the hard palate. If we are able to see all these structures, then this is class 1. And here this is class 2, where this is further compromised. The uvula is partially covered. And here we can see only the soft palate and the hard palate, and here we just can't see anything. So as the grading increases, so there is more chance of having sleep disorder breathing. And we have to then encourage the patient to maintain a sleep diary. So what's a sleep diary? It's a record of the patient's daily sleep and wake pattern. So he has to maintain a sleep hygiene and has to maintain a sleep diary. It can be recorded by the patient himself or herself or any caregiver who can record the sleep diary. And it has to be filled for a minimum of 2 weeks to know the exact pattern of sleep and wake pattern. So it is usually filled up by the patient after 1 hour of waking up in the morning. So if someone is not able to fill up on one day, then they should leave it blank and make brief notes of anything unusual which has affected your sleep in the diary. And one should not bother much about the accurate timings. Just a basic estimate of the time will give us an idea about the sleep and wake pattern of the patient. So this is how a sleep diary looks like. So there will be some questions and on each day you have to mark your answers regarding the questions. Now coming to the assessment of sleep disorder breathing, so there are some common questionnaires which are used in our clinical practice. First, there is Epworth Sleepiness Scale. This scale gives us an idea about the daytime sleepiness of the patient. I'll be showing you. Then there is the Berlin questionnaire, and we have got the Stop Bank questionnaire, which are very commonly used in our clinical practice for screening of patient with sleep disorder breathing. So this is Epworth Sleepiness Scale. So this gives an idea about the daytime sleepiness, how sleepy the patient is during the daytime. So what this assesses, so it gives 8 scenarios during the daytime. There are 8 scenarios and for each scenario you are asked whether what would your likelihood to doze off, means whether you would never doze, slight chance of dozing, moderate chance of dozing and high chance of dozing. And the scenarios are sitting and reading, watching television, sitting inactive in a public place, as a passenger in the car for an hour without a break, lying down in the rest after the afternoon and sitting and talking to someone, sitting quietly after lunch without alcohol in a car while stopping in a few minutes in traffic. So when you ask this, you give these scenarios to the patient and ask him whether how much likelihood there is that he will fall asleep during these scenarios. So then that will give us an idea. So when we, this is slight chance is scored as 1, moderate is 2, and high chance is scored as 3. So there is based upon the scoring. So if it is usually more than 10, then there is high likelihood that the patient is sleepy during the daytime, and so there might be a sleep disordered breathing. This is a Berlin questionnaire where there are which has taken into account the signs and symptoms of the patients, as well as some other physiological measurements. So again, based upon the scoring, there is high likelihood of sleep disordered breathing or less likelihood of sleep disordered breathing. So all these questions, I mean the boxes which are highlighted, if those are marked as yes, then there is high likelihood of sleep disordered breathing. Now, this is a very simplified questionnaire, the stop bank questionnaire, which is very easy to use. S stands for snoring. Only you have to answer in yes or no, and 1 point for each correct answer. Yes, positive response. And if 0 to 2 is low risk, 3 to 4 is intermediate risk, and more than 5 is high risk. So S stands for snoring, whether there is snoring is there or not, yes or no. Tiredness, do you feel tired, yes or no. O for observed apneas, as I was telling you during the history, if there are observed apneas, then you have to mark it as yes. High blood pressure, BMI, if it is more than 35, age, if it is 50 years or more, neck circumference more than 40 centimeter, gender, if it is male. So these are the risk factors for obstructive sleep apnea. So STOPBANG, so stands for stop bank. So this questionnaire is very commonly used and is very helpful for screening of patients for obstructive sleep apnea. Now, once we have done a preliminary evaluation of the patient based upon the detailed history and the clinical examination and questionnaires, then the patients who have got more likelihood of sleep disorder breathing, we then take them to the lab to confirm our diagnosis. We do a polysomnography. So what is a polysomnography? It's a non-invasive, pain-free procedure, usually requires spending the night or two in a sleep lab, and usually the lab is designed in such a way to give a feel of a bedroom, a typical bedroom, so that the patient will feel at home and will usually fall asleep. If there are many medical gadgets or something like that, the patient might get scary and might not fall asleep. So, and usually there is a sleep technologist who hooks up the electrodes, the EEG electrodes, the EOG, EMG, all the electrodes that can be simultaneously, that usually records multiple biological functions during sleep. It's a digital recording made. And then the data is analyzed the next day to assess the sleep study. So this is how a patient. This was a patient who had come to us. He was weighing around I think 120 or 125 kilos, and he was planned to undergo bariatric surgery because of this morbid obesity. So this is how a patient looks like when he is hooked up for during a polysomnography. So there are multiple channels which are applied on this patient. You can see the EEG channels are there. So the brain wave activity is measured by the EEG, which are placed on the head. Then there are the eye movement, which is recorded by the EOG oculogram. Then there is the muscle tone, the chin EMG, which is recorded by placing the electrodes below the chin. Then the airflow, we have to see, measure the airflow, whether it is normal or it is decreasing or it is totally absent. So airflow via thin catheters placed in front of the nostrils and mouth. You can see here there is the catheter placed here. Breathing efforts via the belts placed over the chest and the abdomen. So this is the chest belt, which is the abdominal belts. So these belts record the movement of the chest and the abdomen during the respiratory movements. So if there are no movements, there will be absent movements which they have got sensors placed in that chest belts. Then snoring, there is a microphone placed here within this this device here, which is placed in front of the mouth. Then the ECG electrodes are present there. The oxygen level is measured by the pulse oximeter, which is placed on the fingertip. And then the leg muscle also has to be applied. I think the photograph was taken before it was applied. The body position sensors are there in the belts, and also there is facility for video recording, so that can observe, so it can be recorded if there are any abnormal movements or abnormal behavior of the patient during the sleep, so that the video recording will record those phenomena. So this is how these are the recordings usually made in a overnight in-lab polysomnography, which is done to diagnose the sleep disorder breathing or any other types of sleep disorders. So what are the different types of sleep studies? Now we should be knowing this. So first is the diagnostic polysomnography. So whenever there is a suspicion of any sleep disorder breathing or any other sleep disorder, so we do a diagnostic test by overnight polysomnography. So the patient is hooked up with the electrodes and then sleeps the entire night, and then in the morning they are disconnected, and then we go through the tracings, and we assess we make a diagnosis. Then there is positive airway pressure titration studies, where once there is a diagnosis is made of obstructive sleep apnea, then we need to know the exact. We all know that the treatment for moderate to severe sleep apnea is a CPAP machine, a machine which delivers a continuous positive airway pressure, so that it creates a pneumatic splint and it keeps the airway open during throughout the sleep. So, but we need to know the right pressures which has to be applied to keep the airway open. So for that we need to do a titration study. So once a diagnostic study is made, the next day, maybe next night, the patient is called for a titration study, where the patient is again made to sleep with the CPAP machine, and the manual titration is done by the sleep technologist, where gradually he increases the pressure, and the pressure at which all the respiratory events are abolished, that is the pressure which should be prescribed to the patient to use the CPAP at home at that particular pressure. So that is a PAP titration study. Then there is a study called split night study, where in the same night we can do a diagnostic as well as the titration study. So during the first 2 hours of sleep during the diagnostic study, if the technologist observes that there are the number of apneas and hypopneas are very high, so means there is a high severe OSA is there, then there is no point in observing the entire night for diagnostic study. So we can break in between, and we can start the titration, doing this titration but we have to make sure that at least 3 hours of sleep, 3 to 4 hours of sleep is left behind, so that the titration we will get enough time to do a titration, PAP titration for that patient. So that saves a lot of time, and also it's economical. Then there is another type of sleep study called the MSLT, that's a multiple sleep latency test, and there is also maintenance of wakefulness test. So usually multiple sleep latency test is done during the daytime in patients to diagnose. Usually it's done to diagnose either narcolepsy or idiopathic hypersomnia. So those patients are diagnosed by multiple sleep latency test, where during the daytime the studies is done to look at the latency, how much time the patient takes to fall asleep. So for diagnosis of narcolepsy, usually this at 2 hours interval it is done, and if the latency is less than 8 minutes, and if there are at least 2 sleep onset REM, means immediately there is onset of REM sleep, then it is diagnosed as narcolepsy. Similarly, there is maintenance of wakefulness test is there, where it's done to see how whether the patient is able to maintain his wakefulness during the sleep when they are provided a quiet environment. especially these are important for useful for patients who needs to maintain a high level of wakefulness during their job. So again, based upon the type of polysomnography, there are 4 types of studies, that is level 1, level 2, level 3 and level 4. So level 1 and level 2 are basically same. The only difference is that level 1 is the complete polysomnography along with which is supervised by a sleep technologist in the lab. Whereas level 2 is also the same recordings, but that is usually done in the home without any sleep observation by a sleep technologist. So that is the only difference. So, so in the level 1, we have got the cardiorespiratory as well as the neurological recordings. All recordings are there, right from EEG, electrooculogram, electromyogram, ECG, thoracoabdominal movements, airflow, oximetry. Everything is done in type 1 and type 2 studies. But in type 3 studies, these neurological recordings are missing. So we have only got these cardiorespiratory channels in the type 3 and type 4 study, which are usually done during the home sleep testing. And they will only just detect whether there are respiratory events, there are apneas are there or not, and there are desaturations are there or not, but we will not be able to observe any staging of the sleep, and we will not be able to know about the neurological recordings. So now coming to the interpretation of the polysomnography. Once we have done a polysomnography, how to interpret the results. So usually it's a very tedious process. It's experienced person can complete in 2 to 3 hours, but initially it takes a very long time because the entire tracings you have to go through. Then it is usually done in 30 seconds of recordings. It's called an epoch. So epoch by epoch we have to observe, and we have to make a first we have to make a stage of the sleep, then we do the respiratory events scoring. So each epoch is assigned a stage of sleep based upon the EEG waves. We have to assign a stage to that sleep. So then once the sleep staging is done, then we go for the respiratory event staging, whether the patient is having apneas or hypopneas or RERAs or whatever. So apneas are scored by oronasal thermistor. So the thermistor which is placed here in the nasal, which detects a change in temperature of the inhaled air and exhaled air. So that detects whether there is cessation or respiration is there or not. So the thermistor detects the apneas. Hypopneas are scored by the nasal pressure transducers, so which detects a fall in the airflow, and that can give us an idea about whether hypopneas are taking place or not. During PAP titration, the PAP device flow signals is used to score respiratory events, and respiratory effort is scored by thoracoabdominal belts, as I had told you in that when I had shown you in the diagram. So this is how a normal polysomnograph tracing looks like. So there are different waves. So I don't think it's visible clearly. So on the top we have the EEG channels, we have got the EEG recordings, we have got the EOG recordings also, oculogram, the different EEG waves. Then we have got the respiratory movements, the thoracic movements and the abdomen. We have got the oxygen saturation here, we have got the body position here, whether it's supine or left or right. So this is a complete recording when this is how a normal recording looks like when we go through a polysomnographic recording. So if you look carefully, we have got this, this is the airflow. So we can see there is complete cessation of airflow here in between, and in between there is airflow. So when there is complete cessation, but the respiratory efforts are continuing. So although there is no airflow, but there is respiratory effort. That means there is the effort is there to take in air through the compromised airway. So that is obstruct. There is an obstruction. So that indicates there is obstructive sleep apnea. And also followed by following the event, there are usually arousals. There can be arousals, and also there can be desaturations following the events. But because of this, and this event, whenever we this event should be more than 10 seconds. So that is the definition. Apnea should last for at least the event should be 10 seconds or more. Then only we can tell that it's an apnea. When there is complete cessation of airway, but the respiratory effort will be there. So that is how we detect obstructive apnea. Now coming to central apnea, again here also there will be complete cessation of the airflow, but there will be no thoracic or abdominal effort because the signal from the brain is not there. So it's a central sleep apnea. So in central sleep apnea, there will be no airflow and there will be no respiratory effort also. That is how we distinguish between obstructive sleep apnea and central sleep apnea. Then there can be some episodes of mixed apnea also, where there will be complete absence of airflow and followed for 10 seconds, and the effort will be absent in the initial phase, but there will be effort in the latter phase. So this is a mixed apnea, which has got features of both obstructive and central apneas. Then there are hypopneas. What are hypopneas? So there is partial collapse of the airway and there is decrease in the airflow. There will be decrease in the airflow, and again it has to be for a duration of 10 seconds at least, and then it has to be, the decrease has to be for at least for 30% decrease in airflow, and it has to be followed by a desaturation of 3% or more. So that is the definition of hypopnea. So how to look for it? Then we can see that the airflow is, as we compare here, the airflow is definitely less here and the respiratory effort is there, but there will be significant desaturations. Post this event, there will be desaturations, more than 3%, and there can be arousal also. So usually, this is how hypopneas are scored. Then there is another entity called respiratory effort related arousal, or RERA. So basically it is the events when they do not fulfill exact criteria of apnea or hypopnea, then you can stamp it as RERA. Means there are respiratory events, but it is not exactly fulfilling the criteria of apnea or hypopnea. But it is followed by an arousal. So we call it as RERAs. Now, how to diagnose obstructive sleep apnea? So all the apneas throughout the night, all the hypopneas, they are totaled and divided by the total sleep time. So this is very important. The total sleep time, it is not the total recording time, it's total sleep time. Then that gives the apnea hypopnea index. So if the index is less than, if it is less than 5, that is normal. So 5 to 10 is mild, and 5 to 15 is mild. More than 15 to 30 is moderate, and if his HI is more than 30, it is severe. So obstructive sleep apnea. So now question comes to manual scoring versus auto scoring. So the polysomnography, after it is done, even the machine can generate its own automatic report. So nowadays this is mostly done in the clinical practice because the manual scoring is a very tedious process and has to be done by experienced persons only. So auto analysis is less sensitive, especially for sleep stages and deep sleep and REM. So frequently we see that in the patient comes with the auto generated report and there is no REM sleep at all. REM sleep is 0. So they are less sensitive for REM to detect REM sleep, and auto scoring is also poor in detecting hypopneas. So it can give a low AHI also. Auto analysis of respiratory variables have good sensitivity and specificity for high AHI cut, but not for the lower ones. Now, what are the components of a sleep study report? When a polysomnography has been done and the patient comes with a sleep study report, how to read that report, that also is very important, so that we can interpret the report in the right way. So it has got, the first part is the patient information, where everything is mentioned, the patient height, weight, the BMI, everything is mentioned about the patient. Then there are some technical details, which leads, how many leads have been used, what channels have been recorded, those are mentioned here. Then there is the respiratory event summary and also the sleep architecture, means how much time the patient has spent in each stage of sleep, that is mentioned there. And there is also the sleep architecture and the respiratory event summary here. So means what was the sleep latency, how much time the patient took to fall asleep. Then what is the total recording time, what is the total sleep time, what is the sleep efficiency, that is the percentage of time the patient has spent during sleep during that entire night, that is the sleep efficiency, whether the patient has slept adequately or not. So all those informations will be provided here. Then there is the oximetry data regarding the oxygen desaturations, whether the patient is having significant oxygen desaturations or not during the sleep, and also the hypnogram. That's a summary of the sleep study, which is given in just one page. So the components of a sleep study report, we have got the total recording time, total sleep time, sleep efficiency, sleep latency, and REM latency. So these are important for interpreting a sleep report. Then stages of sleep, usually a person normally spends 5% of time in the N1 stage. Most of the time is spent in the N2 sleep, then N3 20%, REM 25%. This is the rough time spent by a person in the different stages of sleep. So if you find anything abnormal, then we have to again interpret it in the right way. So the sleep summary here, if you can see an example, total sleep time is just 81 minutes, whereas the total recording time is 403 minutes. That means patient has not slept at all. So this is very important. This is the basic thing. So before going for the interpretation, if the patient has not slept adequately, then the interpretation is not, we cannot make a conclusion out of the sleep report. So here the sleep efficiency comes to be only 20%. For some reason, patient has not slept at all. Whether the patient might, it's sometimes called the first night effect. Means when the patient comes suddenly from his home to sleep in an alien environment, then might not feel comfortable. That might be the reason, or for some other reason, patient has not slept at all. Then the wake after sleep onset, that is 313 minutes. That means patient has been awake after this, he has fallen asleep. So that's the reason that the sleep efficiency is very less. There is no REM sleep at all. This REM sleep is important because while we are doing titration, when we are doing titration for positive airway disease, positive airway pressure devices, so the titration can be stamped as optimum only when we go to REM sleep, and that too in supine position. So when there are no events, no respiratory events taking place in the REM sleep in supine position, and that pressure is usually the right pressure which the patient has to use at home. So that's why the REM sleep recording is very important. Coming to the respiratory summary, so obstructive counts, there were 66. Hypopneas 37, mostly so obstructive events were there, and AHI 77. So this is a severe, more than 30. So this is a case of severe obstructive sleep apnea. This is a hypnogram summary in one page, which gives us an idea about the entire night study. So the sleep stages are there. You can see the different stages. Then here we have the obstructive events, obstructive apneas. These are the apneas, these are the hypopneas, these are the mixed events, and also these are the desaturations. And this is a hypnogram of a split night study. So we can see here, for the first half of the night there were many events, but for the second half there are no events at all, because this is a split night study. After 2 to 3 hours of recording, when the technologists saw that there are severe events, the frequency of events is very high, so he has put on the PAP device, and the patient has responded well to the PAP device, and there are no events at all. So this is, looking at the hypnogram, we can have an idea in the OPD that yes, the patient has responded well to the PAP, so patient might be doing well with PAP at home also, so we can prescribe the right PAP device for the patient. I think I will stop here.
Thank you so much.
Thank you for this patient hearing.
Thank you, Dr. Saurin. It's a very nice talk, and very easily you have diagnosed the sleep disorder in OPD, and you have highlighted on your topic very nicely. Thank you very much.
Thank you.
Thank you so much. May I request the organizers to felicitate Dr. Saurin. May I request Dr. Manjari to felicitate Dr. Saurin.
Thank you, Saurin sir. I would like to request Dr. Manjari Tripathi madam to felicitate Saurin sir with a token of appreciation. Now I would like to request Professor Dr. Ramaran Mahanti sir, our ex-DMET and our professor during our UG career, to take the chairperson for the next scientific session, and Professor Dr. Bimuchi Madam, HOD Department of Microbiology of this institution, to take the chairperson for this next scientific section. Neurodegeneration. This neurodegeneration, whether it's a manifested disease of geriatric age group or it will be manifested in the geriatric age group and the symptoms started from younger age. For this wonderful topic, I would like to request Dr. Manjari Tripathi Madam, neurologist, AIMS Delhi, for this topic of impact of sleep disturbances on neurodegeneration.
At the outset, okay, I'll just, you have the slide here? My bad.
Please put the biodata.
Yeah, I'll speak about myself. Okay. You know, I'll brag about
Thank
myself.
you very much. You don't need any introduction,
So
madam.
I'm Professor Manjari Tripathi. I've done my MBBS from MKCG Medical College, Odisha, Katha Parchi. Then after that I did my DM Neurology from NIMHANS, Bangalore. Then after that I went for my fellowship, which was both the sleep fellowship as well as the epilepsy fellowship, to UCLA, and did a American Academy of Sleep Medicine fellowship in Northwestern Chicago. And then I've been a faculty at AIMS Delhi since then. Currently head of unit, and I'll be talking about so I'll be talking about sleep in neurodegenerative disease. So thanks to COVID, we've got used to two modes of learning. One is online and one is offline. So this is, real learning. But sleep is something which is online or offline. We are offline. During sleep, we are all offline. And do we like to be offline? Yeah. So traditionally, I think in Odisha, everybody used to value sleep. At least when I was doing my MBBS, sleep was hugely valued. And I think it should be the same now, except that at the time when we were doing MBBS, we did not have so many interventions like iPhones or iPads or laptops. We were mostly doing our presentations on overhead projectors or slides which we used to prepare. So we did not leave anything till the last minute. Okay. To tell you truthfully, my talk for today is also kind of last minute. So obviously if we have equipment with us which allows us to do things till the last minute, we are more likely to lose sleep or less likely to lose sleep? More likely to lose sleep. So we are, through our gadgets, though we think our gadgets are helping us out, even for the presentations we make, the gadgets may actually be making us sleep deprived. So let's learn of how it impacts our brain. And we talk about dreadful disorders, which are neurodegenerative disorders. But before we reach there, we'll talk about normal cognition and normal sleep. So adequate sleep is that which is long enough and good enough for us to feel good the next day. And there is an effect on aging, on sleep. In a young child, this child which is just born to 1 or 2 years till 5 to 6 years, the children are sleeping almost throughout the day. So 20 hours in newborn becomes 19 hours in a 1 or 2 year old. And by 5 years old, it's around 11 to 12 hours. So there is a gradual decline in the sleep and the type of sleep. In a newborn to a infant or a 1 or 2 year child, it's polycyclic. They sleep many times a day. They get up, they sleep. They get up, they sleep. Whereas as we grow, it becomes either it is 2 times a day or in the night, consolidated in the night. So in children generally, less than 10 years, 11 years, they have almost all stages of sleep in all the cycles. So you will have 1, 2, 3 REM, and then you will cycle back 3, 2, 1, then again you will go to REM, and again you cycle back. So you have good REM and good stage 3. Children have a lot of stage 3 and REM, and this is very, very important when it comes to learning and memory. When we become a little older, the stage 3 reduces, which is the slow wave sleep. Stage 3 sleep is characterized by high amplitude delta, fitting in more than 20% of or 50% of your epoch. So stage 3 sleep reduces as we grow older. For example, we at our age, or many of you at your age, will be having lower stage 3 sleep as when you were children. And why do you think that nature has made stage 3 richer in children compared to us? Because children need to learn, they need to memorize, they need to put things in their head, for use later. So obviously stage 3 is going to be more in young brains and is going to reduce as we age. And when we become elderly, when we cross 60 or 65, then the REM reduces dramatically and stage 3 almost becomes very less, and mostly stage 1 and 2. And the duration of sleep also reduces. When we grow older, we'll sleep only for 6 hours or so, and some elderly find it possible to sleep only for 4 to 5 hours. So it changes with age. Now, how are sleep and cognition related? Before that, we should know what is cognition. So basically, all what we do is cognition, whether we perceive it through our various senses, and we know what the senses are, the sight, the smell, the hearing, the taste, and the touch. All these are receptors for forming memory. So basically, perception leads to development of memories. And then of course, the fact that we have language and we've developed language, and we are not talking like orangutans or monkeys, that we have refined language to communicate it in various languages, whether it's Odia or whether it's Kannada. And then of course, we have to be attentive to the task, and if you're not attentive to the task, we are not going to be processing anything cognitively. And then we have the capacity for thinking and problem solving, and then of course forming memories, and that is what is generally known as human intelligence. In other words, cognition is the acquisition of any new information, which all of us are doing right now, and the ability to store this and retrieve it at a later date for use as and when needed. It involves several processes, which includes attention, working memory, comprehension, language, calculation, reasoning, problem solving, and decision making. Of late, there is another realm of cognition which has been added to classify a person as having dementia, which we'll talk about. So how is it that the basic process of cognition, which is the formation of memories, occurs? When we perceive stimuli by these 5 sensory organs which we have, this stimuli goes into our sensory memories, which, further on, whatever happens, will require a lot of parallel processing. It's not one unilateral processing, it's a lot of parallel processing which happens in a network mode. So sometimes you can forget the sensory memories, which is the perception by the sense organs. At that level, you could have a forgetting. And if you've paid enough attention to the sensory, input which you were having, whether it's auditory like this talk I'm giving, or whether it's vision like the slides I'm showing, then it will enter from the sensory memory. The memory will enter your short-term memory. You could also forget at that stage. And then of course, apart from entering the short-term memory, because you've given attention to my talk, it needs to go into your long-term memory, which requires the process of encoding. And from the long-term memory, you have to dive deep down like a diver dives into the sea and retrieve the memory. So which part of this do all of you think sleep is needed for? Yes? Only encoding, not attention? Suppose you haven't slept yesterday night, will you be attentive today in the hall? Almost every part of this process you require good sleep, and so let's look at it. The last realm of cognition which is being discovered and is being described to define dementia, certain dementia disorders is social cognition. So social cognition is something which we really don't care about or don't talk about, but basically it is information processing about all people, including ourselves, about norms, procedures in the social world. Some communities have grossly impaired social cognition, and this is becoming important, particularly in frontotemporal dementia syndromes. Social cognition is that part of cognition which is basically enabled by the frontal lobes, mainly the mesial frontal cingulate, anterior cingulate cortex. It helps us judge situations, it helps us simplify our problems, and social cognition is again superseded by another cognition which Dr. Arpita often talks about, that is metacognition. So metacognition is that part of cognition which is responsible for self-awareness, self-monitoring, learning, strategizing, using judgment and intuition. All these processes, not just the memory, the social cognition and the metacognition, all get transformed by improper sleep. So what is metacognition? It is cognition about cognition, and this is very important when we want to place ourselves within a community or a structure. So there are several changing concepts of cognition which are very exciting, and in other words we can divide cognition into cold cognition and hot cognition, and then you have social cognition somewhere in between. So hot cognition is the cognition which we often have in relationships between husband-wife, between mother-child, and between mother-in-law, daughter-in-law. It involves a lot of emotional processing. So, all these relationship cognition issues which we have, memories which we form, due to emotional processing, emotional semantics, the words we speak in our relationships, emotional prosody, communicating intentions, all these come under the hot cognition. It is a part of cognition. Cold cognition is what we structurally, assess in our neuropsychology tests, which is memory, working memory, attention, language, syntax. It's a very routine kind of cognitive process. Which part of cognition do you feel will be more remembered, cold cognition or hot cognition? Yeah, we often remember memories which are often linked with an emotion. Then of course there is the social cognition, which is theory of mind, social knowledge, attributional style, emotion perception, and emotion processing. Now these are very refined aspects of cognition which many of us may be lacking because we've really not been taught how to handle them. There are several factors which affect cognition for us. They can be personal factors, psychological factors, environmental factors. Nutrition is very, very important. Genetics and physiological factors. Which of these do you think is important? Of these? Genetics? So, okay, so everybody talks about genetics nowadays, so I thought the answer would be genetics. But genetics is just a loaded gun, the trigger of which is pulled by many environmental factors. So, in that environmental factor, an important factor is sleep. So genetics is just a loaded gun, and it will not express itself unless various other epigenetic factors or environmental factors come into play. And so genetics can be modified by looking at these multiple factors, including nutrition, environmental, psychosocial, etc. So coming back to sleep, that was a little bit about cognition, but coming back to sleep, as I said, sleep is a state of disconnect, and it's your responses are reduced, your movements are reduced, it's a slowed metabolism state. Its basic function is to go offline in the 24 hours so that you are online for the next 24 hours to restore energy and well-being, boost immune function. We saw a lot of this during COVID. People who couldn't sleep did worse in COVID. Thermoregulation and tissue recovery. And of course, consolidation of memory. So let's talk about consolidation of memory. Consolidation, we need to stabilize it. We need to enhance it. How do we enhance it? By repeated reading of that paragraph, isn't it? So one is to stabilize it, to read that paragraph, And the other is to keep reading that paragraph, memorize that. So once you've read a paragraph, you memorize it, say after 2 hours, and then you may have forgotten 10 lines in that, and then you go read it again, and then you memorize it again after 4 hours, you may have forgotten 5 lines in it. Then again you read that paragraph, and then again you try to recollect, you may have forgotten only 1 line in it. So that is your process of enhancement, which is due to reverberating circuits. And then of course you can recall it later. So there can be a loss or erasure during all this process of integration and translocation. The basic purpose of sleep is to enhance this, and sleep is essentially a night school and is the offline mode in which you can actually consolidate all this to recall it later. So this is in Nature, which is the highest rated journal. You can see sleep is equated with a night school, and the whole process of enhancement as well as stabilization could occur due to various neurochemical and synaptic processes which happen in sleep. So what are the neurochemical processes which happen? You can see the green, which is non-REM sleep, and the pink, which is REM sleep. In the non-REM sleep, you have a decrease in acetylcholine, whereas in the REM sleep, you have an increase in acetylcholine. Is acetylcholine a pro-memory chemical or anti-memory chemical? Yes? Pro. Acetylcholine is a pro-memory chemical. Mind you, the only drugs which are available so far for managing dementia work on the acetylcholine esterase enzyme, preventing the enzyme to break down acetylcholine and hence increasing acetylcholine levels in the brain, which stabilizes memory in patients with dementia. So basically, though non-REM has certain amount of acetylcholine decrease, it also has a cortisol decrease, and excess cortisol will benefit the memory or harm the memory. If you're taking a lot of steroids, what happens to your memory? It reduces. So there is a balancing effect. So though the acetylcholine reduces, the cortisol is also reducing. Whereas in REM, the acetylcholine increases. So traditionally it should improve your memory, but cortisol also increases. So you really have to have a balance of these stages before you can, realize that memory chemicals are adequate in your brain. So let's look into so that was at the chemical level, but at the processing level, what is going on? So here you can see there is effort for encoding, and this is in the wake state. So we are rectifying whatever we have learned, and it's probably going into the long-term store, and also it has a temporary store. Whereas when a person sleeps in the slow wave sleep, there is an active consolidation of the temporary things which we have learned into a more consolidated state which occurs. So basically, in the wake state, there is a rich connection between the cortex and the hippocampus responsible for temporary storing, and in the sleep, due to this various sleep morphologies or microarchitecture of sleep spindles and slow waves, there is a consolidation of this temporary memory into a more permanent form of. This is also important. This is again a very physiological topic about memory. There are two kinds of memory. One is the declarative memory, and the other is the non-declarative memory. And what kind of memory do you use when you drive your car and come to work? Yes? It's a declarative memory or a non-declarative memory? It's a non-declarative memory. It's a procedural memory. So it doesn't require to go on learning again and again how to drive your car or how to swim or whatever. So implicit memory, or memory which gets encoded and remains within us despite whatever the circumstances, that is, we can do it as a reflex, is what is known as implicit memory, and in that comes priming, which is located in the neocortex, procedural memory, which is the striatum, which would come into action when we drive or swim, etc., or bicycle, associative learning, classical and operant conditioning, which is to do with emotional responses and skeletal musculature. So if somebody is coming barging at you and you want to, escape that person, you will either duck or you'll slap him. So that's coming as a part of this associative learning of classical or emotional conditioning, which is regulated by a very primitive part of the brain, which is amygdala. And then of course you have to have the skeletal musculature associated in this kind of memory, because you won't know what to do. If you see a tiger, you want to run, the skeletal musculature has to be involved in this, and that's negotiated by the cerebellum. Non-associative habitual learning is by reflex pathways. Whereas explicit memory, which is what students require to pass the exams, is of two kinds, semantic and episodic. Semantic is the fact. So how would I say semantic as an example? So today I am in Puri, I had a very good experience of a very good Saraswati Vandana. So that will go and fix in my semantic memory. That's a fact which happened in Puri. It benefits the declarative memory. That's why your capacity to ratify is there only till you pass your MBBS. Then you get to your post-graduation, it's difficult to ratify because the slow wave sleep is highest and largest in till you know you're 20, 23, 24. When you go and become 35, 40, you will not be able to do the declarative stuff which you were doing as you were a school child. So, because your slow wave sleep is reducing in amount when you grow older. When you grow older, you're more likely to remember facts or semantic things. You're likely to remember, you have what is known as a fluid memory. You will remember the concepts, you'll remember the reasons behind it. But to go on memorizing again and again, it may be difficult. For example, when I did my DM neurology, spinocerebellar ataxia was only spinocerebellar ataxia. There was no type 1 or type 2 or type 3. But now the residents have to learn spinocerebellar ataxia's type 61 also. So you can imagine what is happening, what we learnt at that time and what they are learning now. It requires a lot more declarative memory now to learn the spinocerebellar ataxia, what is type 1, what is type 12, what are the clinical features of type, whatever. So REM sleep benefits non-declarative memories. So non-declarative memories means your implicit memories as well as your emotional processing of memories is by REM. So both parts are important. So if you look at motor procedural memory, for both perceptual and procedural tasks, they improve following sleep. So even if you have to learn a new skill like archery or whatever, you have to have good night's sleep because it is going to improve both procedural as well as perceptual. And there is an overnight improvement with good sleep of procedural tasks. That's why they say that in your last day of your, whatever skill you have to do, you must sleep well. Sleep spindles are particularly important in improving the motor sequence tasks. Whereas emotional memory, which deals with emotional memory of emotional intonation of words and pictures, is also, very importantly done in the REM sleep, as I said. It has been seen in psychiatric disorders which mainly deal with emotional misperception. The REM sleep is, having abnormalities. Now, some people ask me, is it okay to sleep in day or night? So we know memory is superior if you sleep or you sleep over what you have learnt. But night sleep is seemingly superior to day sleep in terms of memory. So if you have to learn something for an exam, it's better to get good night sleep than study the whole night and then sleep in the day and say you have slept 7 hours, so your memory is going to be good. Because the quality of night sleep is being physiologically built to synchronize with all the hormonal secretions, and that is why that synchrony is broken if you sleep in the daytime. So it's always better if you have to learn things to have consolidated night sleep than sleep in the day. Sleep during the early part of night produces higher rate of remembering than sleep during the latter part of night. That is why they say people who sleep early and get up early learn better, because you are sleeping during the early part of the night as compared to the late sleepers who are sleeping during the latter part of the night, and this has been shown by elegant experiments by Gray et al. Now, just over the past 6 to 7 years, a very important structure of the brain has been discovered, which Dr. Arpita mentioned in her talk. What is that structure? The lymphatic system. So previously nobody talked about the lymphatic system of the brain. The lymphatic system is the lymphatic system of the brain. As you can see here, this is the awake state and this is the sleep state. In the sleep state, there is a CSF influx and there is a lymphatic structure which activates itself, and this is responsible for clearing all our metabolic waste which go to the brain. And this is a huge new discovery, particularly pertaining to dementia. So if you're not sleeping in the night, I know of clinicians, very, very busy and renowned clinicians who do their OPDs till 1 or 2 in the night and they don't sleep. And then again they have to go to hospital and they get up very early in the morning to get to the hospital because they also hold government jobs. So they're doing private practice as well as government job. So the government job will allow them to work till whatever time, then they go to their private clinic, and the private clinic, obviously there are so many patients that they cannot stop their practice, and they're practicing till 11, 12, 2, and so the sleep is severely compromised. So this is going to impact our cognition at later age. We are going to have issues with memory and learning. Whereas in the awake state, there is no metabolic clearing or very little metabolic clearing. That is why sleep is essential for the lymphatics to dilate, and I'll show how they work. So basically, the green pathway which you see, it is activated. All the toxins which is in blue gets out of the brain during the sleep process. So this is just a short video. This is the sleep state and this is the wake state, and you will see how much amount of toxins are getting out during the sleep state. I hope the video plays. Okay, for some reason it's not playing. So basically the video was showing during the sleep state there is a dilatation of these pathways which are the lymphatics. It dilates and that absorbs or pulls the toxins as compared to in the wake state. So this has been recently discovered by Nedergaard et al. From the Finnish countries. So lymphatic clearance is going to be compromised if the sleep is poor, and this is going to lead to beta amyloid accumulation, which is then going to lead to dementia. So what is the commonest sleep problem right now with us? It's not a disease, it's something which is within our control, and that is sleep deprivation. So sleep deprivation is the commonest pathological lifestyle we have now. And what is the definition of sleep deprivation? Not giving yourself an adequate opportunity to sleep. You yourself are not giving yourself an adequate opportunity to sleep. Well, when doctors are doing night duty, I understand that it is required. When nurses are on duty, it is required. But most of us who are not on duties and not on BPO shifts or whatever, are not giving ourselves an adequate opportunity to sleep, particularly young children, particularly busy clinicians running very hectic OPDs in private practice. So as a result of which, the amount of sleep is reduced to 4 hours. Now somebody said that everybody's sleep is personalized, okay. Sleep always does not, lack of sleep does not always manifest with excess sleep the next day. It may manifest with emotional dysregulation. It may manifest with bad judgment. So you may make poor decisions. You may be emotionally dysregulated. It happens with me. If I have an acute sleep deprivation, next morning I am very trigger free with my emotions. I get irritated. I lose my cool. I may not be very clear in my thinking. So I confess that I do have this effect on me. I don't know whether because I am in a hyper-aroused state of teaching and learning, I don't have excessive daytime somnolescence because I have slept only 4 hours. It manifests in another way. So we have to look at various ways at which sleep deprivation affects us. It's not necessary, it affects us with EDS. So what are the short-term effects of sleep deprivation? It's going to impair attention, concentration. Even in talks like this, people who haven't slept yesterday night will not be able to attend and concentrate too. It impairs quality of life. It increases the chance of absenteeism because you haven't slept in the night, you're going to miss out on work next day. Decreased productivity and increases accidents on the road. So sleep deprivation leads to a lot of things which are including neurodegeneration by causing memory problems, deranged blood pressures, fatigue, obesity, depression, and in men erectile dysfunction. So let's look at data, scientific data. I'm not talking, off the hat. The red is the total sleep deprivation. The people who were totally sleep deprived, look at the number of attention lapses they had. Whereas people who slept 8 hours had better attention. So which is the first entry point for formation of memory? You receive the sensory stimuli, you have to be attentive to it. Whatever I am talking, whatever Arpita talked, whatever other speakers talked, if you are not attentive to it, will it enter our memory? It will not. So if we are sleep deprived, the first step of formation of memory is not going to happen. And so we are not going to recollect how many of our lectures we may sit through. So not only does it affect attention, it also reduces perceived emotional intelligence and constructive thinking skills. So creativity will come down. Your ability to think out of the box will come down. Your emotional intelligence of what to say and what to not say in a particular situation will come down. The second most commonest sleep problem is insomnia. So what is the definition of insomnia? Sleep deprivation was we did not give ourselves an adequate opportunity to sleep. Insomnia is I am giving myself an adequate opportunity to sleep but still not getting sleep. Is it understood? I am giving myself 8 hours but still not sleeping. I go to the bed at 10 and I get up at 6 or whatever and still not getting sleep. So I am giving myself an adequate opportunity to sleep and still not sleeping. If this occurs in teen tagada, kaam bigada, that is 3 days a week, 3 days a week for more than 3 months, it is chronic insomnia. And if it occurs for less than 3 days a week and less than 3 months, it is an acute insomnia or a intermittent insomnia. Many of us have intermittent insomnia, isn't it? When we have an exam or suppose a function in the family or a wedding, we may not sleep on that particular night, or some conflict at work, we may not get sleep. So that is an intermittent insomnia. But if this pattern continues for 3 weeks, more than 3 days a week for more than 3 months, then it will become chronic insomnia, and that has lots of consequences. And one of them is cognitive impairment. So insomnia also leads to neurodegeneration. Not only neurodegeneration, it has even cancer increases, accident risk increases, quality of life worsens. So basically you're going to have impaired performance in insomnia, and you're going to have decreased motivation. The most important thing in learning is motivation. You have to have motivation to sit in this hall, otherwise you can be enjoying some radio music or some movie. So motivation is also reduced in insomnia. They say, "Kon panchibi, sabu to achhi boi re, pori de paper." So insomnia will cause that to happen. Okay, so this is what it's happening. It's causing difficulty coping, difficulty accomplishing tasks, and affecting family life also. So usually a typical insomniac will have all these complaints. They'll be always too tired to do things, sleepy driving the car, and of course general trouble remembering, confused thinking and judgment, impaired memory, impaired performance. So this is not me speaking. Many great rishis, as Arpita calls them, have done research and shown that. So basically there is a sleep dependent memory consolidation which is impaired in those, and there's a reduced amount of slow wave sleep. And we remember slow wave sleep is very essential for formation of encoding and consolidation of memories, which is not going to happen. So people have done so many studies that a meta-analysis could be performed of 24 studies. Okay, so 24 studies were meta-analyzed, which is the best way to run large amounts of papers. And you can see here, what is to this side, what is crossing is not important. What is to this side? Memory, working memory, retention, manipulation of the memory, episodic memory, procedural memory of course was not impacted. But these three, the memory which we require to learn new things was gone in insomnics. And this is by meta-analysis. It's not a single study. It's a study of 24, analysis of 24 studies. So we have to identify insomnia. It is a big problem. People don't come forward. And what do insomnics do in our country? They go to the shop and they take alprazolam and they become addicted to alprazolam and nowadays to many other things to try to sleep. So that is going to worsen memory, because alprazolam is a benzodiazepine. it's going to inhibit your glutamate receptors throughout the day, and it's going to further impact memory. So drug-induced dementia is huge in our country because people are taking alprazolam over the counter. Also, they are taking SSRIs like amitriptyline and other antidepressants for a long time without knowing that antidepressants taken for a long time can impact memory and learning. So let's go beyond sleep disorders now. We talked about sleep deprivation, we talked about insomnia. So sleep deprivation and insomnia problems, you know, their sleep problems are traditionally classified as those people who can't stay asleep, those people who can't stay awake, and then abnormal behavior in sleep. So neurodegeneration is something which is linked to almost all sleep issues. So if you have obstructive sleep apnea, you're likely to have vascular dementia and strokes. If you have obstructive sleep apnea, you're likely to have dementia. If you have restless leg syndrome, you're likely to have Parkinson's disease. If you have RBD is an harbinger, REM sleep behavior disorder. That is, in REM sleep, in REM sleep normally there should be, what happens to the muscles in REM sleep? Atonia. So REM sleep behavior disorder, there is loss of atonia, and there will be movements in REM sleep, and that is a harbinger of Parkinson's disease and multiple system atrophy. And of course, sleep deprivation itself can cause seizures. So how does sleep impact dementia? So this is a neurodegenerative disease. Dementia is not something which any one of us would like to have, nor want our relatives to have dementia. So basically, there are a lot of sleep disturbances which occur in dementia and also which cause dementia. So patients with dementia will have shifted circadian rhythms. They will have decreased sleep. They will not sleep in the night, they will sleep in the morning hours, so the caregiver's sleep is not good. They can have restless leg syndrome, they can have sleep apnea. Now, let's go to Alzheimer's dementia. Alzheimer's dementia is the prototype of dementias where memory is impacted mostly, new learning. And you can see here in Alzheimer's dementia, there was reduced slow wave sleep, decreased sleep spindles, and increased arousals. Then there is a bidirectional relationship and a causal interaction between non-REM sleep and amyloid beta pathophysiology. So what was found is, if you have reduced non-REM sleep, obviously your lymphatics are not going to push out the toxins and amyloid beta is going to accumulate. This has been shown in animals as well as humans by amyloid beta scanning. So it is not something which is theory, it is very much observed. So let's look at the various sleep times. Suppose somebody is sleeping 6 hours, which is considered short, 6 to 9 hours, which is the reference, which is normal, and more than 9 hours, which is long. So till now we were talking about reduced sleep. Now, in my experience during my MBBS, most Urias have increased sleep, not reduced sleep. So not only they sleep in the night, they also sleep in the afternoon. So if you're sleeping more than 9 hours, what happens to your cognition? This is the Framingham Heart Study done by Sudha, who was also from Ames and now in Harvard. So prolonged sleep of more than 9 hours. So they divided patients in these 3 categories, and they found patients who had prolonged sleep of more than 9 hours were, likely to have onset of Alzheimer's and dementia 13 years before the baseline. Baseline was what? 6 to 9 hours. So you have to take account of your sleep. Don't go on sleeping unnecessarily. Avoid unnecessary sleep also. So long sleep duration was associated not only clinically but was also associated with smaller cerebral brain volume. The volume of the brain reduced if you sleep excessively. So prolonged sleep was a marker of early neurodegeneration. So not only inadequate sleep, but also prolonged sleep. So again here, this is a meta-analysis of 18 studies. So let's look what they found. That was Sudha Seshadri's single study, but there was a meta-analysis of sleep duration studies, okay, not just one study. And they clearly found long sleep was associated with poor cognitive function. So nowadays most watches have a facility. They almost, Apple Watch has a sleep and wake. Even your Samsung phone has a sleep and wake. So if all of you have smart watches, you can monitor your own sleep. It's like Not a fully scientific actigraphy, but it is a partial actigraphy which you do. So basically, long sleep has to be avoided. So what are the mechanisms? Now the next disorder which patients with dementia have is sleep disordered breathing, which the previous speaker told about. Sleep disordered breathing, your oxygen is going low every, suppose you have sleep apnea which is severe. Severe is 30 per hour. So 30 times in an hour or more than that, your oxygen is going down. In an hour, you have 60 minutes. In those 60 minutes, 30 times your oxygen is going down. So what is that going to do? It is going to lead to sleep fragmentation, oxidative stress is going to increase, and it's going to cause intrathoracic pressure swings, which are all going to cause a cognitive decline. So basically, patients with dementia who have sleep apnea are more likely to develop a rapidly progressive dementia. So how does it affect? It causes an increase in the amyloid beta, it causes synaptic downscaling because of hypoxia, and it causes enhanced, not only it prevents clearing of amyloid beta, hypoxia causes enhanced amyloid beta formation, reduced clearance of amyloid beta. So you can see it's very scary. Insomnia can cause cognitive issues, sleep deprivation can cause cognitive issues, and sleep apnea can cause dementia. So basically, there is a higher risk of dementia in those who have OSA, and they are 26% more likely to develop cognitive impairment. So sleep is important for neurodegenerative disorders. There is a significant correlation between AHI and the severity of dementia and the onset of dementia. The higher your AHI, the more likely that your cognition is going to go down. So what happens? What is the management? So since it's seen in about 50% of patients with dementia, it's a reversible cause of cognitive decline, and it was seen in the study that in patients who received CPAP versus those who did not receive CPAP pressure, which was sham CPAP, they just put the mask but the pressure was not put on, there was a less impairment as compared to those who were not given CPAP. It's not just one study, there are several studies. So you can see several studies here, and the randomized studies, RCTs, not the non-randomized studies, showed that sustained CPAP use was associated with lesser cognitive decline. So if you have a patient who has early cognitive decline and you pick up the OSA and you treat it, there is less likely cognitive decline. So it is a reversible factor where you can intervene. There was a study which was done to demonstrate that, which was a randomized study which is highly quoted, which is known as the Apple study. It is a 6-month study of active or sham CPAP, and the people who used CPAP had an improvement in executive and frontal lobe functions. So that was dementia, but before dementia there is a stage which is known as mild cognitive impairment. So mild cognitive impairment is a stage where there is involvement of a single domain or two domains of cognition without making the person dependent on another person for his day-to-day needs. So that is mild cognitive impairment. It is a harbinger of dementia. 25% of mild cognitive impairment patients will annually convert to dementia. So you can see here that those people who had sleep disordered breathing were more likely to be diagnosed as having MCI at a later stage, and not only were they more likely to be diagnosed than with MCI at a later stage, they were likely to be diagnosed with MCI 10 years earlier than those without sleep disordered breathing. So pickup of sleep disordered breathing is very important, and mild cognitive impairment in those who had sleep disordered breathing started 5 to 10 years earlier than those who did not have sleep disordered breathing. It's not just Alzheimer's dementia, but Parkinson's disease with dementia is also associated with several sleep disorders, whether it's REM sleep behavior disorder, whether it's RLS, whether it's periodic leg movements, or associated with excessive daytime somnolence. So there are several sleep. You can see here, you can see all the kind, even nightmares, daytime sleepiness, which is excessive daytime somnolence. The worst is RBD. So normally in REM state you should have atonia, but here in REM state there is active tone in the EMG muscles and the patient has rapid eye movements in the eye channel. So he is in REM sleep, but his tone is not lost. His tone has actually increased. So this REM sleep behavior disorder is a harbinger of a neurodegenerative disease, and people still do not know how it predisposes to neurodegeneration. It could be via the glymphatic pathway is one of the mechanisms that is being hypothesized. It is very disruptive for the bed partner because the person starts beating them or starts moving in the bed so much that the bed partner is not able to sleep. And there are diagnostic criteria for it. If anybody is interested, I could give it to them. There are two kinds of RBD, idiopathic and secondary. Idiopathic is where the RBD persists without resulting in neurodegenerative diseases. But generally a patient who has RBD 10 years later will develop a neurodegenerative disease. That's why we like to follow up these patients. 90% of patients with RBD go on to develop Parkinson's or MSA or dementia or even have narcolepsy. So it's very important that we look for these neurodegenerative disorders and we keep patients with RBD on follow-up. It's not just neurodegeneration. In our study of the SAVE cohort, which our center also participated in, we also found that patients who had obstructive sleep apnea had higher depression. So not just neurodegeneration, also psychiatric disorders are associated with, like depression, are associated with sleep disorders. So the moment you treat it, the depression improves. So one of the causes of depression whose cause is not known, you have to screen whether the patient has OSA or a sleep problem which is leading to depression, because even insomnia can lead to depression. So always any psychiatrist who's seeing a depressed patient must go into the sleep history, because there may be insomnia, there may be OSA which is leading to the depression, which is reversible or potentially manageable. So I'd conclude by saying that sleep dependent memory consolidation is very, very important. It is almost related to all sleep disorders, whether it is narcolepsy, OSA, insomnia, sleep deprivation, RBD. All of these can lead on to neurodegeneration in mild forms like mild cognitive impairment, in Alzheimer's disease forms, in DLBD form or PD form, or even in patients with mood disorders. Hence, sleep quality and quantity is very important, and of course early awareness and intervention is very important. The psychiatrist must take sleep history, the neurologist must take sleep history, the physiologist must do more research, because this area is absolutely nascent. People do not know. The glymphatic is a discovery which has happened only in the past 5 or 6 years. So, proving it in humans is just 5-6 years. 2012 mein to Niedergard described it. And neurodegenerative diseases are really scary because they are irreversible. So if you can do the step 1 and step 2, maybe the burden of neurodegenerative diseases could reduce. Thank you.
Thank you very much, Dr. Manjari. You have elaborated the sleep, its type, its disorder, and the treatment. Everything is very nice and educative. Thank you very much for being here. Thank you.
Thank you, ma'am, for the wonderful session. Now I would like to request Dr. Rama sir to felicitate Dr. Manjari Tripathi ma'am. Next we will proceed for our delicious lunch for 30 minutes as we are already late.
Just 10 minutes, let me see whether it is ready. It is ready or not?
Okay, ma'am.
Have you seen it is ready or not?
Oh, it's already all come. All came. Ready, mane kaadusund hegale. Thank you all. Hospital, Bhubaneswar, and Professor Dr. Bibhupada Mahapatra sir, Department of Physiology, to take as the chairperson for the next scientific session. No one till today thought about the switching of lights in ICU setup. So how can the patient manage their sleep for this purpose? So now I would like to request Dr. P. Sarachandra sir, neurosurgeon, AIMS New Delhi, to speak about the sleep in ICU. Thank you.
Dr. Arpita, it's okay. I can introduce myself like Dr. Manjari. Okay. So good afternoon. I know I have a difficult time because it's a postprandial period and I have to speak on something which you should not indulge into right now and keep your attention wide open. So to introduce myself, I am the professor and head of Unit 1 at the All India Institute of Medical Sciences, Department of Neurosurgery in New Delhi. So I have passed out from MKCG Medical College in the year 91. And then of course I did my residency from NIMHANS, and then I was in UCLA for a couple of years doing my fellowship in epilepsy surgery. And then we started a very nice epilepsy surgery program at AIMS. We also got a Center of Excellence for Epilepsy through a grant from Department of Biotechnology. It has all the 4 verticals of research as well as magnetoencephalography, which is a very advanced brain mapping machine. And then it also has, we have done large number of epilepsy surgeries, currently more than 3,500 surgeries. That's one of the largest centers in the world. Published more than 500 papers. So that gave us a lot of academic satisfaction. I'm also active in other pathologies like craniovertebral junction, minimally invasive neurosurgery, but never unfortunately in sleep. But then I have to make myself useful for this particular podium and also have the challenge to keep you awake. And I requested Dr. Arpita, yes, I would like to speak on sleep in ICU because that's something which is very, very relevant for us. And then of course I'd like to give a talk which I would show you what exactly it is about. So first is my talk on sleep in ICU, so which is relevant for today's topic for the symposium. So I asked my resident to send me this couple of photographs, which is from the AIMS Neurosurgery ICU at 2 a.m. So you can see that the lights are very much on and the sound of monitors keeps on going, and nobody is so much actually bothered about the fact that the patients should sleep comfortably. It's more about survival. It's more about trying to keep the patients alive and avoid the many complications. And neurosurgery ICU happens to be one of the most intensive ICU care because we operate really complex cases and we do something like 14 or 15 surgeries a day, and all of them are really major cases. So sleep is something which is not in anyone's mind except for the residents and nurses. Only they think of sleeping, but they don't actually think of anybody else. But it's been a big learning experience, you know. So when I went through the literature, I saw what is the relevance of sleep in ICU setting, and that gave me a number of revealing things which are very, very important, and I think we should also share with all our colleagues. So as we know, ICU is a highly complex environment. It requires constant monitoring, observation, and as a result of this, like I was telling you, it's more about survival of the patients. Many times the humanizing aspects are often overlooked. So we see patients, you know, they come out of surgery, are being electrically ventilated, so both the hands are tied to the bed so that they don't pull out the Ryle's tube or the enterotracheal tube. Often the patient is conscious, and it's unimaginable to think how they would sleep with a tube whole night. What is the quality of sleep? And there is no doubt an increasing evidence that sleep is severely affected. And there is also evidence coming up that sleep deprivation may adversely affect recovery. So with this four or five sentences, we went through the literature. And when we would like to assess sleep in ICU, I asked Manjari what could be the possible mechanisms we could do. Obviously, a full grade polysomnography is not possible in ICU. because even to install a full grade polysomnography, you will require so much of time, and then if they're operated, they have bandages on the head, obviously that's not possible. But definitely you could assess them by using a level 3 PSG, which contains only an oxygen saturation nasal probe and a chest belt. And in addition, you could also use actigraphy, fundamentally for the knowledge of students sitting here. It's an accelerometer based wristwatch, which is there in all the Apple watches. So you could use a similar device like that, which detects the body movements. But however, studies have shown that they have a poor correlation. They don't have a very good correlation to the actual quality of sleep. Bispectral index is something which is now very commonly being used in our setting. So we use it to look for the depth of anesthesia. So especially when we have to do aneurysm clipping and we give barbiturate for cerebral protection. So we want them to go into a certain phase of neuroprotection. We use bispectral index. So that fundamentally detects EEG patterns and has a score of 0 to 100. And higher scores basically indicates higher levels of consciousness. So that is one thing which could be easily used, but again, there are not many studies. But surprisingly, there has been good correlative studies for subjective evaluation. And the advantage of subjective evaluation is that it could be easily done bedside. So for instance, we have this RCSQ evaluation, which is found to be very reasonably correlating with actual sleep studies. And that indeed is a good news, because you could use them very well even without any facilities available. You could use the subjective evaluation scores for assessing critically ill patients. Now, sleep in ICU disorders definitely are very common, but it's most underrated and most neglected. And the reason is we think or we assume that most of the patients in the ICU only have an acute retention period. So they would shift out of ICU in a couple of days. That is what we would imagine. But then if you go to especially to any neuro ICUs, you'll find approximately 30% of the patients are long-standing patients. So they have had chronic illnesses like head injuries, or they've been operated for some tumors because of which they're still dependent on ventilator or for bed care, and they would be lying. So for instance, in our ICU, we have at least 20 or 30% of the patients who have been there for several weeks to months. And obviously now we need to look what is the quality of life. So when we do rounds, we don't actually think about all these things. The only thing we do is looking after the nursing care. Now there is a study which has been done by Elliott et al. It's about a decade-old study, and he has demonstrated that almost 90% of these patients have affection of the superficial sleep, mostly deprived about deep and restorative sleep, which is NREM phase 3 and REM sleep. So obviously we know that there is now enough evidence to show that most of these patients have severe sleep affection. Now critically, now it's also been shown that most of the sleep is fragmented for patients in the ICU. So they could get sleep for some time and again wake up. So as a result, their quality of sleep again is disturbed. Now there was a study which looked into the ICU survivors. It was a very interesting study. So they gave out a questionnaire. So obviously, staying in ICU leads to bad memories. You underwent some surgical procedure. Obviously, it's not for some happy reason that you are admitted in ICU. And most of the patients on follow-up, they continue having inability to sleep because of major stress, or they keep on having severe panic attacks. And when they studied, they found that up to 40% of the patients continued to have sleep disturbances even after 6 months. So even if these patients were admitted in ICU for less than 7 days, they still continue to have sleep disturbances for more than 40% of the cases. So definitely it's quite significant. Now, what are the causes of sleep disorders in ICU? So the most important is noise. Now it has been shown that the noise levels in ICU is comparable to that in factories and industrial areas. So the amount of noise in ICU is not less at all. My father-in-law was admitted in ICU for a couple of days. He could not sleep, and he would complain that I could not sleep. It is too noisy here. So when some of our own family members are admitted, that is when we come to know how difficult it is. So noise is definitely one of the most important factors which leads to sleep deprivation. Now light is second most important thing. But however, surprisingly, when I went through the literature, it was less disturbing than noise. In fact, there are studies to show that the melatonin secretion in ICU patients was erratic, and this was irrespective whether the light levels were high or the light levels were dimmed. So that's one surprising thing what I found in the literature, but perhaps more studies have to be done. There's just a couple of studies in order to ratify this result. And of course, you have a lot of other patient interventions like oral hygiene, bathing, changing of bed linen, catheter management. So, and most of these activities are performed at midnight between 12 to 5, even in our ICU, because in the morning you have rounds, so all the patients have to be prepared. So either they are done from 12 to 5 in the midnight, or maybe from 3 a.m. till 6 a.m. So all these activities have to be done before the morning shift of sisters come. And one study calculated an average of 51 interventions every night. So again, you can imagine that your sleep can go for a 6. So you have other factors which include intrinsic to patients. So patients are stressed out, they have pain, or they are worried about their illness because of which they cannot sleep, or mechanical ventilation. So particularly conscious patients on mechanical ventilations, they have severe disruption of sleep because of sleep fragmentations. Then medications. So many times when the patients are restless, we use without thinking, drugs like benzodiazepines or sedatives or analgesics or antipsychotics. Again, these have severe impact on sleep. So whenever we deal with chronic patients, these are the factors which we need to consider. That do we need to give these medications? Do we need to stop these medications and give them something which could be much more natural or much more friendlier to induce a natural sleep? What are the potential consequences? A lot has been spoken about this. I'm not going to speak more about this. We all know that it has a lack of sleep can have severe cardiovascular impact, and this is a study which has been quoted. It could have severe issues with respiration, but of course there are no ICU studies. Again, Dr. Arpita was speaking about glucose tolerance, growth hormone, even the appetite hormones like leptin and ghrelin, which induce appetite, even they are severely reduced. So obviously you have, the whole system is completely disturbed. But what has been shown in the ICU, similarly in immune system, we have all heard from excellent lectures earlier, they can lead to changes in immune function in lymphocytes, inflammatory cytokines, insulin resistance, and so on. But what is established is that almost 80 to 90% of the patients who are on mechanical ventilation have acute delirium. So that's an acute confusional state. So that is something which is almost universally present. You ventilate a patient for a couple of days, the patient will 100% go into an acute delirium or a psychosis, because that patient loses the sense of what is day and what is night. So these are the patients, where you need to think of strategies on how, and it is very well established that acute delirium leads to higher mortality, then use of higher amount of sedatives. So the outcomes, so delirium and acute confusional states, they have to be treated properly. So what are the measures by which we can improve sleep promotion in ICU? I think the biggest measure is awareness. Most of us are not aware of it, or at the back of the mind, even if you are aware of it, we don't like to give it so much of importance because our mind is burdened with hundreds of other things in the ICU. So we are thinking if the electrolytes are normal, or the ABG is normal, or the patient is improving, there is no sepsis, any complications. I think this level of awareness has to be brought both in the staff and as well as the doctors. And that automatically will create, a solution for instance, somebody has to discuss something in ICU. Like once I was sitting, suddenly some sister will start shouting and everybody's sleep is woken up. So people are not sensitive enough, when they are in the ICU, they think they're in an acute situation. So I think awareness is the most important thing. But apart from that, you have a lot of other factors. So most of the ICUs are switching on to single room ICUs. So if you go to ICUs anywhere in the West or any other places, even including AIMS, we are switching on to single cubicle ICUs where every patient would have a single cubicle which has glass so that it's soundproofed. Then reduction of monitor and ventilator alarms. Often what happens is unnecessary alarms are always on, and the sisters or the anesthetists don't look into it. So there is some godforsaken alarm which keeps on going on which has no relevance. So there are at least 10 to 12 alarms which needs to be switched off. Otherwise the ventilator is going to keep on making noise every few seconds. It's very important to dim lights. So you have an ICU setting, you should dim lights, encourage sleeping masks. It's very important, I think, from a neurosurgeon's perspective, that you have to synchronize both the patient's ventilator and as well as the patient's breath. Most often we find, patients are fighting with the ventilator. That the reason is the ventilator is pumping gases which is not synchronous to the patient's own breathing. And of course, you have patient measures like adequate pain relief. Now, using drugs like zolpidem and melatonin, I think, would be much more useful. So rather than giving them benzodiazepines for standard acute post-operative settings, you could give drugs like melatonin or zolpidem that could be more physiological. And of course, it would be luxury to have something like music therapy or some kind of a gentle massage and psychological counseling. But these are the things, which sound very nice on theory, but it's very difficult to apply on practice, especially in an acute setting or in an overloading setting like ours. But yes, when you think of solutions, these are the things which you could think of. Now, I looked into any kind of studies which was present, which showed that if you provide these measures, there could be actually some improvement in the patient's sleep patterns. And I came across this very interesting study. So they used earplugs, eye masks, relaxing music, melatonin, and then they found that definitely it improved the sleep as assessed by the subjective scores. But however, there was no difference in urinary cortisol or melatonin level. But definitely in terms of patients' subjective parameters, there was good improvement. So concluding, I would say that sleep affection in ICU is something which is highly underrated and neglected. Most of us would not like to give attention to this because there are many other things, but it's high time that we started paying attention to this. And there are several recent studies which are emerging to show its relationship, how it is important for optimal patient recovery. And sound is the most important cause, so we should see how the sounds can be reduced. Nowadays you have noise cancelling earphones, so you could use that very effectively. So I went once to an ICU in Singapore. So all the ICU survivors, up to 40%, have prolonged sleep disturbances. So sleep assessment should become a regular component of patient assessment, especially in the ICU setting. So I think I have learned by reviewing the literature quite a lot. And definitely from my perspective, we will try to implement this when we go back, because it's something, which has been, we don't actually go through this in our busy lives. So that's the end of my first talk. So if there are any questions or any comments. Okay. Thank you. So this, I thought I can give it because couple of reasons why I thought I should give. So firstly, definitely I'm not such a sleep expert as Dr. Arpita or Dr. Manjari. So this is, I thought I'm kind of not up to the mark trying to give a lecture in front of such leading experts. And then of course this is something which is based on my own personal experience. And this has been my talk for various presidential orations, keynote lectures, parts of it, not all of it. And I thought I could present it here. It does have some philosophical overtones. My apologies if you think I'm moving more towards it in a scientific forum. But I'd like to speak about these three things. And I think these three things are very important to all of us. How many of you are MBBS students here? MBBS students? Postgraduates? Could raise your hands. So plenty of postgraduates. So I think when you're trying to go ahead in career, perhaps my idea was perhaps you could pick up some things from this. So speaking about situational awareness, I read this nice story in Chanda Mama. I found this very old book in my mother's home and I started reading it, and there was a story of Vikramaditya. And you could remember those stories of Vikramaditya, and this was one of the stories. I'm not telling you the entire story, but fundamentally the story was about a king, who does a lot, but still he has that sense of dissatisfaction. Perhaps I don't remember, but then he meets a sage, and he asks the sage. He says, "Oh wise one, please tell me what will it be which will affect me most as I get older? What will it be which will come into my thoughts and make me lose my sleep? What will it be which will make me ruminate again and again and make me wish that I had done this?" And this he says because as we get older, we start having lots of thoughts and we think, should I have done that? We have many regrets. We feel satisfied about many things. But obviously we always get bombarded by thoughts. And this is what the sage replied. So the thought which is going to, and this is for the youngsters, as you get older, these thoughts are going to come into your head, wherever you are. So the thought which comes to most of us is, did I actually contribute anything worthwhile to the society? You could have earned millions of, lakhs of rupees or crores of rupees. You could have built a huge house. You could have done enough for your family. You could have done well for yourself. But at some point of time, I believe this thought is going to come to you, that did I actually contribute anything worthwhile to the society? And it's not important that how much you actually did, but how you feel about it. It's a subjective feeling. Do you feel happy about yourself, that did I actually contribute enough to this society? And then the king asks back, what will happen if I feel falsely? I'm going to lie to myself. I'm going to say that, yes, I have contributed enough and I'm going to be happy. So who is it for anybody else to judge whether I have contributed adequately or not? And the sage answers, your heart will not allow that. If you look into your heart, it will tell you if you contributed adequately. I think this is one question which is going to come up into each and every one of our lives as we become older. And this is all based upon the Eastern thought. It comes to everybody. But our wise seers have realized this hundreds of years ago. And that is why in Hinduism, the crux of the Eastern philosophy is that we give a big importance to subjectivity. And that's very different from how the Western civilization looks at science. It looks at it in a very objective manner. And my apologies if I want to make it more clear. So in the Eastern philosophy, you have a concept. It's an underlying concept. And Dr. Arpita is a fantastic philosopher. She could provide me more wisdom on this. Manjari always keeps on telling, Dr. Arpita has sent me this post, Dr. Arpita has said this. So perhaps she could give me a few wise words on this. So according to Eastern philosophy, objective observation is nothing but a common observation made by a majority of the people, which leads to a creation of that reality. It's a very deep meaning. It says that nothing is objective. And in fact, it could sound ridiculous to the point that you say that even this glass doesn't exist. This glass exists because every one of us truly believe that this glass exists. And that is how the glass has come into reality. So Ramana Maharshi was asked that, "O sage, please tell us how can we help others?" And he answers, there are no others, there are only us. Which means this comes to the core tenet of the human philosophy, which says that the observed and the observer are the same. So there you don't have existence of another person. You are all the part of the same living being. Now look at this in contrast to the Western philosophy. Western philosophy says that I am different, you are different. So I'm going to make a couple of observations, and if my observations match up to something, then we will say that it's relevant. And that has been the basis of randomized controlled trials, which are good in a certain platform, but do they hold relevance when you go into more complex situations? Do they hold relevance when you move from a linear pattern to a non-linear pattern? And this reality started cracking, when people came up. For instance, Feynman came up with one electron theory. So which fundamentally means that there is only one electron which exists in the whole universe. And that's the reason that every electron is exactly the same as another electron. So no thing is duplicated in the universe. But how is it that one electron is exactly an electron which is vibrating front and behind the time? It's going forward and backward in time, and it's creating copies, illusory copies of itself in the whole universe. So he says that the whole universe is actually made of one electron. So we are all connected in that way. And then I've been fascinated by Heisenberg's uncertainty principle. So this is an equation, we have all read it in our physics when we were preparing for +2. But the fundamental aspect of Heinsberg's theory is that it says that when you observe something, whatever you observe, that itself changes. So that doesn't remain any more constant. So fundamentally it says that if you visualize something by a group of photons, so the whole thing deviates, so you cannot make anything accurate. But fundamentally it means that whenever you do an act of observing something, that itself changes. So that brings into an act that things are absolutely relative. Reality is not as we see it. So this is a very famous saying by Claude Bernard, which says man learns nothing except by moving from known to unknown. So unless you become uncomfortable with yourself and try to move into an unknown spheres, that is where you actually start learning. If you are within the same comfort sphere, you will never end up learning. So here, forgive me if I sound inappropriate or if I sound a bit foolish, but I will move forward with a sense of trepidation, as I'm going to apply a certain degree of subjective science and philosophical intonations to my life's journey. And again, this has been part of my various orations. So I asked Dr. Arpita if I can give this lecture, and she was kind enough to agree for this. Disclosures. So I'm not an epitome of success, nor do I believe I may be the right person to speak, but still, I believe I'm a learner in this path, and I'm free to express my opinions while on this journey. And I had to put this disclosure because the biggest critic of my life is sitting right there. So if I speak about philosophy, she is going to raise her eyebrows and say, Acha, so this guy is now speaking about philosophy. So situational awareness. What is situational awareness? This is coming up in a big way. So fundamentally, situational awareness is knowing where you are and what is going on around you, allowing individuals and organizations to be more alert and informed and to make better decisions. So this is something which is coming up in every organizations. So if you look situational awareness, if you punch in Google, you're going to get at least 200 to 200,000 searches. You're going to get a lot of materials. So fundamentally it means that how you are aware of yourself as well as your surrounding environment. So if you look at our Prime Minister Modi, he was asked, how come you're able to sleep only for 4 or 5 hours? He mentioned that I'm able to have very good sleep at night. So I would say that he practices situational awareness to the highest degree, so he's able to execute what he could sitting on the highest office of this country. Now, situational awareness is very important in neurosurgery. It's very important because you are in an acute situation. Things can change from every second to second, minute to minute. If the assistant is not proper, he's sleeping and it retracts the brain a little too much, there is contusion. If he doesn't concentrate, he could rupture a blood vessel. So a lot of things can happen. And so it's very important for us to really practice situational awareness. And many of us do. We do it unconsciously. But it would be very nice if somebody could provide you certain tips on how you could go about it. And I read a lot of material. And I thought situational awareness in neurosurgery could be divided into these 5 categories. And I will tell you what exactly this means. So how many of you have read, I suppose everybody would have read about Alice in Wonderland. So in Alice in Wonderland, has everybody of you read it? I'm sure it's the commonest book you would have read. So in Alice in Wonderland, you have the Red Queen. So Alice asks the Red Queen, he says, why are you running? So the Queen answers that in our country, you have to run twice as faster to stay where you are. That's the precise answer she gives. It's kind of a I would say it's a symbolical abstract to what we are going through in the current times. Now, how many of you read this book called Homo Deus? Could you raise your hands? It's okay if nobody have read. Wonderful. It's a fantastic, it's a fascinating book. It's a sequel to Homo Sapiens. And one of the things which they say that how men have become superior to animals is because we have shared imagination, shared trust, and shared dreams. By shared imagination, it means that, Dr. Arpita is able to dream about how to treat patients having sleep disorders, and so is Dr. Manjari able to dream about it. And they're able to connect their imaginations together. And when we say shared trust, humans have such a deep inherent ability to share trust. For instance, I give a note of 500 rupees. So inherently I trust that the 500 rupees I'm handing over to the other person has that particular value, so that the person is going to give me that amount of value to me. So that's a very, very basal and a very deep-rooted level which the humans have been able to develop, unlike animals. And of course, we have shared dreams. But one of the side effects, one of the fallback about these three things about humans, shared imagination, trust, and dreams, is that we have forgotten how to stay in the present. So forever we are running. So for instance, we are sitting here. Some of you may be thinking, when is this lecture going to be over? Or when are they going to serve tea? Or when I'm going to reach home in the evening? Or what am I going to do in the evening? Or what is the program for today evening? So these things, so we have somehow lost the ability to stay in the present. We are always trying to run in the future. So one of the fundamental tenets for situational awareness is learn to soak in the present. At a certain period of time, it's going to be impossible. You will realize that it's impossible. But becoming aware that it's impossible is a first step to understand that. Now, my daughter joined psychiatry in Oxford, and then I was amazed to find that almost 40% of psychiatry in Oxford is mindfulness. And in fact, Oxford is leading mindfulness in whole of UK in terms of psychiatry. And they have this number of mindfulness. It's something which has originated from the East, but now it's being very rapidly taken over by the West. You have these mindfulness apps which are earning billions of dollars and people practicing mindfulness, and you have the schools, people go on to these resorts and they they teach you what mindfulness and all that. But what is exactly mindfulness? And again, that is another aspect to look at situational awareness. Mindfulness is the ability to look at reality as it is. So this is what, Jiddu Krishnamurti said is your existential suffering. So at this point of time, when you have a certain inherent restlessness in you, when you have a certain inherent boredom in you, when you have a certain inherent sleepiness in you, or you're not able to concentrate, so you don't have the ability to stick on to that. You are still getting into some dreams or some words or some actions or some situations in the future, or you're thinking of past. So the ability to look at things as they are is what is mindfulness about, and that's the next component of situational awareness. And it goes back very deep. So it fundamentally means do not indulge in wishful thinking, see things as they are, stick to the current present. It's slightly different from what I've spoken about earlier. The third component of situational awareness in neurosurgery, and this is a lecture which I've given, is to visualize how you would actually go ahead and do the surgery. Now, visualization is not ruminating into the future. It is looking at certain specific actions which you would do in future, so that when you enact the future as it comes into the past, you're able to do it perfectly. And it's very good to visualize this. For instance, I'll show you a video of a very complex aneurysm which I clipped. So the whole aneurysm is actually taking up the anterior communicating artery. So you have to think how you can clip this aneurysm, saving all the perforators, because these perforators are supplying to the hypothalamus. And then you have to pass then you visualize how it has to be done. And then finally you enact it, pass the clip behind it. So you can see I'm passing the aneurysm clip and then kind of excluding the aneurysm and then creating the artery out of the aneurysm clip, so that now you're creating the anterior communicating artery. So visualize this is something we do it regularly in neurosurgery. You look at a tumor, you need to visualize how you need to operate it. And that is actually a part of situational awareness. So that's how it is clipped. And this is all done through a very small eyebrow incision so nowadays we clip all the aneurysms through a very small incision. So it's just a size of, you can see 2 centimeters from the eyebrow. Then plan. You need to always plan the surgery. I've often seen surgeons, they don't actually plan anything. So when they're doing surgery, they say, oh, the suction always gets blocked. And then the anesthetist goes on telling them that this patient is losing blood. So the surgeon doesn't listen. Finally, when the patient goes into hypotension, he says, why didn't you tell me patient is going into hypotension? So obviously planning is something which you need to do. So for instance, I wanted to show you this clip, but again, it will be too neurosurgical. But again, this is a complex aneurysm where we were sure that this aneurysm will rupture intraop, but we were ready for it because we could plan for it ahead in future. So you can see when I'm trying to dissect it, the aneurysm suddenly ruptures. But we were ready for it. We put suctions there. So we were able to control it, and then finally we pass. So this was more or less like an elective rupture. So rupture of aneurysm intraoperatively is a catastrophic event. So we finally go ahead and clip it. So planning ahead in future is very, very important, and that is one of the components of situational awareness in neurosurgery. Then finally decapitate from mind. So we had a very interesting session. I was one of the keynote lectures for complications, International Conference on Complications for Neurosurgery, which was held in Mumbai by one of my very good senior colleagues. And then we took a vote from the audience that, let us say you're operating a very important patient. And then suddenly there is a, horrible complications which is happening in the OT. So what is your response? What do you think? So initially people were not coming out upfront. Some surgeons said, no, I don't let it affect me. I have made my mind very strong. I will never get affected. Then other person said, I will just recite Mahamrutyunjay mantra and then everything is fine. And then the senior people slowly started coming out. So one surgeon got a very senior neurosurgeon. He says, when I have this complication, I get a sinking feeling in my heart. It's a really sinking feeling. It's as if, a terrible tragedy has happened to some of my loved ones. And I think of my family. And then this thought comes into my mind, of all the subjects, why did I ever choose neurosurgery? Why couldn't I have done psychiatry? Why did I get into this kind of specialty where I have to deal, with brains on the table? But most of the experienced surgeons said that even though initially you have an acute reaction, you have that sinking feeling, you feel as if something has terribly gone wrong, but they recover very quickly from that. So they say that after some time there is a sense of decapitation. It's as if somebody is chopped off her head, and then suddenly the mind becomes silent. And this factor allows us to go ahead and deal with the situation. Because if I let the mind interfere, then I would never be able to treat and go ahead and treat the patient or tackle the complication. So decapitating from mind is, I think, one of the important. I think all of us come across acute stress reactions. Everything is okay. Suddenly somebody calls up and says that one of your parents have died, sudden heart attack. There is an acute grief reaction. But then when we are ready for this, yes, there will be a grief reaction, but then there is after some time, your thoughts stop, and then you go ahead and do whatever is necessary for your mother or your father. So I think this kind of reaction is what is very, very part of situational awareness. I'll say a few words about section. I hope I'm not running out of time. How much time I have, ma'am? Good, I'll finish it up. So let me know when my time is over. I was asked to give this lecture on what is your definition of success. And we had this debate on annual neurotrauma conference. And I was very hesitant because when people start giving such topics, it means only two things. Either you've stopped operating or you've started getting older. Because when you do that, that is when people start giving you topics like this. What is your spiritual journey? What is the success? But anyway, I prepared this and I really liked it. So if you look at success, success, I think success doesn't actually exist. It's an illusion. It's like the circle, when you draw a circle, because you draw the circle, the center emerges. The center actually doesn't exist. So similarly, success emerges. It's a synergistic emergence because of certain factors coming into your life, and then you say that, okay, I'm successful or I'm not successful, and that's the definition which we give it to it. What could be these things? What could be these chunks which could make up the circle? So I have written down few of them. So there could be many of it, but I've written down few of them, and there will be some food for your thought, and this is my way of thinking. And I could go across each one of them individually. One is an ability to link the cause and effect. So the most successful people are able to kind of attach the cause and effect together. And I'll give you an example. How many of you read this book, Dan Brown Origin? Could you raise your hands? How many of you read Da Vinci Code? So fundamentally, Dan Brown is a fiction writer, but however he writes fiction based on real-time events. So whatever events he describes are completely real-time events, but based on that he creates a fiction. So in Origin, it's about a fictitious situation where somebody comes to know that how have humans evolved and where are we going, what is going to happen to humans, let us say about 500 years from now. And then the church doesn't like it because it's against what they have been teaching as per their teachings. And they are trying to kill off these people. So that's the plot. But the situations in the plot are actually real. So all of you would have heard of this Miller-Urey experiment. So fundamentally this was done in the year 1952. It was a path-breaking experiment. So what they did is they fundamentally put some broth here and they passed high voltage electricity. And they were trying to simulate the condition which would have existed in primitive Earth millions of years ago to show that if they were able to do this, are they able to produce any kind of primitive life forms. Now, the experiment itself was a failure. But what happens in this novel, and what has actually happened in reality also, is that they produce a supercomputer which can take all the variables into consideration. So it can take care of each and every variable and run the same experiment thousands of years into future. And when the supercomputer does that, it shows that life indeed emerges after 1,000 years or 2,000 years. So the Miller-Urey experiment was not a failure. It is only that they made observations which was where the time period was too less. They couldn't do the observation 2,000 years later because that's not a span in which human beings live. Now, there are examples where scientists were able to join the cause and effect. And they have made path, they were the path breakers. One of the examples is Kekule. Have you heard of Kekule, who described the benzene ring? So that's he was thinking how the structure of benzene should be. And then he has a dream of how the snake is trying to eat up its own tail. Now the time and effect, he had the dream when he was thinking of benzene. But let us say if Kekule would have had this dream before, when he was a child, before he even thought of working on benzene, would he have been able to make this correlation? It's unlikely. Or let us say if Kekule would have had this dream when he was 90 years of age, would he have been able to again make this correlation? Again, that also sounds unlikely. So I think one of the biggest drawbacks of humanity is we have a limited time scale, and in that time scale we are not able to understand the cause and effect together. Now if you look at this physician, Gajdusek, how many of you would have heard of him? Can you raise your hands? So Gajdusek was a person who described prion disease. So he went and stayed with Papua New Guinea, and he found that these people, they had this habit of, once one of the relatives would die, they would cut the brains and they would sit around the dead relative and eat the brains. And then they would develop this Kuru or prion disease, which would make them progressively bedridden and lose their cognitive functions. And he postulated that there was something poisonous in this brain of the dead relatives, which was making them get this disease. And he injected this brain matter into chimpanzees. And he was able to recreate this disease, and for which he got a Nobel Prize. So he was able to correlate this cause and effect, and he was able to get a breakthrough. So wherever humans have been able to make a correlation between cause and effect, that's where, for instance, H. pylori, that's again a cause and effect. So people, despite it being a normal commensal, now it is thought to be the main cause of gastric disease. So our factors include, we have too many variables, too long a time distance between cause and effect, and of course we don't have many times lack of situational awareness. So this was one of my breakthroughs. I treated more than 1,000 cases of craniovertebral junction anomalies, and we used to do a transoral 2 surgical procedures from the front and from the back. And while I was teaching my daughter about Archimedes' principle, when suddenly I thought, could I put a spacer and correct the reduction? And that led to us developing a universal CV junction reducer. And we have operated more than 500 cases. We got a US patent. We published several papers in high impact factor journals and also as editorials, and these are the papers. And you can see that this severe anomaly, which is according to severe compression, can be completely reduced by this technique, and this has become an universal technique all over the country. So most of the surgeons are able to follow this technique. Now, the second thing is about blue ocean strategy. So how many of you read this book called Blue Ocean, which was published in 2004? You can go ahead and read about it. So fundamentally it speaks about 2 oceans. You have a red ocean and you have a blue ocean. So the red ocean is red because you have a lot of sharks in it, and all these sharks are eating each other, so it's filled with blood. That's why it's called as a red ocean. Whereas blue ocean is completely clear because it's something which you can sail into it and nobody has taken up the subject. For instance, for somebody from physiology like Dr. Arpita, taking up sleep is a blue ocean strategy. If she would have stuck to some very, very traditional physiological topics, perhaps nobody would have been so much interested. So if you look at red ocean, you have lots of competition. That's an area where you have lots of competition. In blue ocean, you create your own competition. Now, most of the people prefer to get into red oceans. So today you ask people, what do you want to specialize in? They will say, oh, I like to do skin and VD. Now, a decade back, nobody would think of skin and VD. Whereas nowadays, everybody wants to get into skin and VD, and now nobody wants to prefer even radiology. Because most of the people want to go into areas where other people are going into. Surprisingly, that's the thing. They would rather be comfortable staying in a red ocean and fighting with other people than to go out into a new venture. Obviously, red ocean takes a long time to establish. Blue ocean is shorter time to establish. So, blue ocean could become a red ocean. For instance, spine and vascular. So, some time ago, nobody in neurosurgery would be doing spine, but nowadays, almost everybody wants to do spine, so it's become a red ocean. Or a red ocean could become a blue ocean if people neglect something, they are no more interested. So again, for instance, nowadays nobody wants to do a CTVS surgery. So there are hardly any takers for it. So in 10 years down the line, it could again become a blue ocean. So when people start taking it again, it could be something in high demand. So these are the new territories which we could enter. So now these are, whichever ocean you go into, I think two things are important for you, at least for me it was. You should have absolute clarity, and there should be a certain ease with you. And this is a poem which has been written by my daughter. It's called Waves of Joy. And I found these two definitions very nice here. So clarity is not always clear blue skies, crystal waters that showcase the rich life contained with it. It's not always a spotless plan to be executed for days to come. It's sometimes realizing that even here, in this messiness and murkiness, you're free to rest. You're allowed to not know what lies at the end of the staircase and take one step at a time. So that, I think, is a very good definition of clarity. Easy. Easy it is to bend, confirm, freeze and fit in. Easy it is to break open, fluid and free, to carve your own art and trust where it takes you. Choose your own easy. So if you want to swim in the red ocean, if you're comfortable with it, swim in the red ocean. Some people are fit to be sharks. If you're not comfortable, you want to get into blue ocean, go into blue ocean. To do as it comes naturally to you. So you can decide which ocean you'd like to swim, but both are okay as long as it comes naturally to you. The next point is, what I think is important for success is finding new cheese. So again, apologies if I keep on kind of trying to find how ignorant. That's not my purpose, but how many would have you read this book? If you have not, you should read this book. It's called as Who Moved My Cheese. It's a story about two mice and two little people. So they used to stay in a hypothetical cheese station C. They used to come to cheese station every day morning at 9 a.m. They used to eat the cheese, they used to gossip, they used to do some work, they used to speak about politics. They used to grumble about the work and they go back to their home by 5 o'clock in the evening. They used to come again next day by 9 a.m., discuss about pension, eat some more cheese and be happy with it and again go back by 5 o'clock. Starts to sound familiar, isn't it? So this went on for years and years, and soon they started thinking that the cheese is never going to be over. One day, the cheese runs out. So the question is, when you are faced with a challenge, how do we react in our life? So these two mice, Sniff and Scurry, they immediately moved out to search for new cheese, which is not most of us, including me. Now, how is someone who immediately got afraid, he got affected, but he was open to go into new possibilities? Hem is a person who says that life is not fair, and he continued to come back to the same cheese station day after day, even though the cheese was not available, and continued to grumble, continued to complain, continued to criticize the government because the cheese was not available. So this is a journey about how, with whom I equate. Yes, I have got afraid in certain situations of life, but then had the opportunity to change. Now this was the place where I started working as a faculty after graduating from NIMHANS, and this is a red ocean, believe me. It's truly a red ocean, it's very, very competitive. So these are few of the innovations which we did. So first was a endoscopic carpal tunnel. We got it patented. Even though we could not get it commercialized, we got a good paper out of it. So it treats carpal tunnel in a couple of minutes. So it's kind of similar to how when it tries to search out for new cheese. So what he does is, in this story, when you go through it, he goes in search for new cheese, and whenever he gets some insights, he writes these insights on the board so that his friend, him, can come later on and take up the same, they can take up the same advice. So one of his advice is, quicker you let go of old cheese, the sooner you will find new cheese. Having cheese makes you happy. So he was going on searching for his new cheese. Then we described this technique for vertebral body hemangioma. So I operated this tumor almost 20 years back, and I lost almost 7 liters of blood. And then I decided this is not the way to do it. And then we started exploring, and then we found that absolute alcohol embolization is a very easy technique to embolize it. This was published in literature in 1930s. So we started injecting alcohol and also same sitting fixation, and the cost of alcohol was less than 200 or 20 to 30 rupees. So we published papers. Now this is being followed all over the country, and I can see this is a severe compression because of vertebral body hemangioma, severe compression. And this after alcohol treatment, you can see that the compression is completely relieved. And this is a video I will not show you. This was a lady who was 6 months pregnant, paraplegic, and she was a wife of a reporter. So we did this treatment, and then she came walking, and then they published it in papers. And the media had a very nice time, because they said that now alcohol can also cause cure to spine tumors. They found it very funny. But the fact is, this absolute alcohol is not edible. It's totally poisonous. And then, of course, we devised a minimally invasive technique for doing an hemispheric disconnection. So doing hemispherotomy is the most complex aspect of epilepsy surgery. This is a patient I operated in Malaysia, published multiple papers. So I can see Dr. Arpita looking at watch. So we published this paper in New England Journal of Medicine, has an impact factor of 175. So a couple of other experiences which we have done for the first time, and more recently we described this bloodless technique of hemispheric disconnection, which was published as a cover page in Journal of Neurosurgery. So what happens to Hav? So he was initially very afraid to explore new corridors, but he overcame his fear and plunged. And when he started tasting the new cheese, he became more and more confident. And I think that was also the case in my life. So initially I was afraid, but when I started venturing into new areas, I was able to create some new, and for instance, this is a pituitary retractor disposable which we devised. It's patented, and this is the kind of tumors we can remove it using that. And then I got into something which was the darkest area of my life, getting into research. Believe me, research is the most difficult thing you can do in your life, especially for a surgeon who has been operating. We wanted to create a center of excellence for epilepsy. So these are the 4 verticals we created. It was difficult work, but we worked upon it, and we published more than 400 or 500 papers. So what happens to How finally? How finally comes to a new cheese station where he finds plenty of cheese, and he leaves a lot of these things for him to come. The book is open-ended about him. It doesn't say whether him has found the new cheese, whether he has actually ventured out. It leaves it open. It says, I think it's indicating the kind of journey you would like to take. So in this book, cheese is a metaphor of what you want to have in your life, whether it's a job, relationship, money, a big house, freedom, health, recognition, spiritual peace, even an activity like basketball, playing or running. Each of us have an idea of what cheese is, and we pursue it because we feel that it makes us feel happy. If we get it, we become attached to it. Maze is where you spend your time looking for what you want. It could be your organization where you work, the relationships you work upon, you have in life, or community you live in. And sometimes the corridors have delicious cheese, they also have dark corners. So when you get into dark corners, it could be sometimes miserable. But when you have friends and family, they help you to come out of these dark corners. So develop good relationships with your family, have a lot of friends, because when you get into one of these dark corners in the maze, they will help you to get out of it. So let's complete the circle. Failure quotient. Failure quotient is a measurement of somebody to fail intelligently. I think the best example is Thomas Alva Edison. Because he was able to fail intelligently 1,000 times, he was able to succeed. Perceptions. So this is the story I would like to read, and I would like to ask you, what is the story actually about? Son of a rich industrialist married to a beautiful lady. However, the second wife of his father threw him out of home. His father dies broken-hearted. He moves into a city, worked very hard. The king of mafia in the city kidnaps his wife. However, he makes some good friends, finally rescues his wife. He starts a successful business venture, finally returns to his home. His stepbrother is overjoyed to have him back. He finally takes over his father's empire. Perfect, ma'am. So this is Ramayana. So once Karna asked Krishna that, Krishna, you had everything given to you on a golden plate. I was nothing. I was an orphan. The day I was born, my mother deserted me. I had to unfortunately get associated with somebody like Duryodhan. I had to unfortunately give away most of my things. At every point of my life, I was at a disadvantage, whereas you were born with a golden spoon in your mouth. So Krishna says, what are you talking about? The day I was born, it was in the prison. There was thunderstorm outside. My own uncle wanted to kill me. I was finally adopted by somebody who were not my parents. And then I had to marry girls or women whom I never loved. I just had to rescue them from demons. And the people whom I actually loved never got married to me. So what are you talking about? So ultimately it's a perception. What is your perception of yourself you have about success? And finally, I believe there is something like a circumference. This is a circumference which holds all these people, all these pieces together so that it forms that circle. And when it forms that circle, there emerges the center which we call or define it as success. And what could be that circumference? For that, I have composed these 4 lines, and I'd like to read it to you. And it is a takeoff from a similar word by a very famous physician. From competition to collaboration, from volumes to value, from individuals to systems, from receiving to contribution, good Lord deliver us to move from I to us. So when you move from I to us, that is where I believe you form that circumference which is going to hold that circle together. So success is ignoring the trees and seeing the forest. Believe me, I have had personally several failures, but I refuse to look them as failures. You could have multiple failures. Normally, when I stand in front of a oration and I give all these papers, all these publications and all that, people only see the front side of me. They don't see what has happened at the back. So success, I think success is also realizing that it is nothing but a positive perception of failure. When you think whatever failure had, if you look at it positively, then it actually becomes success. At that point, you realize that failure is nothing but success. So if you look at this story again, I believe developing situational awareness is very important. I'm not an expert, and I tell it in front of Manjari, who is here, so that I'm not facing any more criticisms. But yes, I believe this is the way to go ahead. And you need to create your own definition of success, and you need to be happy with it. And I think all that will lead to sound sleep. At the end, when you become older, that question which nags you, saying that what have I contributed, I think you'll have a closure on that question. Thank you very much.
Good afternoon to all. Thank you, Dr. Sarath, for speaking so nicely and enlightening us, starting from the ICU, how the patients are disturbed, success in life, and telling us the Krishna story and how to handle the failures. Thank you so much. We'll be definitely motivated by your speech.
Thank you.
Thank you so much for motivating us.
Thank you, sir, for the important information regarding the sleep hygiene in ICU. Now, I would like to request Professor Dr. Sudarshan Puthal, sir, HOD, Department of Pulmonary Medicine, to speak on sleep-related breathing disorder and its complication. Sir, please.
Okay, let me start. Okay, respected esteemed faculty speakers, my teachers, Arati madam, and also extinguished and participants. It's my great pleasure to part of it. Thank you to our beloved elder sister Arpita Appa giving me opportunity being the part of this work. So my topic is about the sleep-related breathing disorder. Few of my observations of the nature. You see, it is my hypothesis, breathing plus quality of sleep probably designed our lifespan, not only in human kingdom, but also in any animal kingdom too. Say, for example, dog, the breathing pattern is hardly 30 per minutes. Dog used to sleep 10 hours per day, and also quality of sleep is very poor. The lifespan is hardly 15 years. Whereas you see the animal or a crocodile, rate of breathing is hardly 10 per minutes, and type of sleep or duration of sleep hardly 17 hours per day, and the lifespan about 70 years. What I mean to say, the breathing, I mean to the respiratory rate and the quality of sleep or type of sleep probably dictate our lifespan. The main topic is related to sleep-related breathing disorder and its complication to OSA. During hardly 30 minutes, I want to cover this type like what are the type of sleep-related breathing disorder, the prevalence and the risk factor, some sort of pathogenesis and diagnosis and treatment. Of course, this is an overview. In the span of 30 minutes, I want to give an overview, snapshot like that, so that everybody will have some fine idea about this disorder. Basically, what happens in sleep, it is a sleep and physiology, particularly normal physiology. You see, sleep is one of a compromising situation of the life. What I mean to say, normally what happens in sleep is a situation where we lost our wakefulness drive. That this wakefulness drive is a somewhat say neurological drive from higher center to control our day-to-day activity. These are lost during the sleep. These are major factor, major hindrance of the sleep. Basically what happens in sleep, naturally normal healthy human beings also, during the sleep, our tidal volume is coming down, our ventilation is coming down. So that the normally in healthy human beings, the about 2 to 8 50 millimeter of mercury rise of say carbon dioxide, as well as 10, roughly around 8 to 10 millimeter of mercury fall in oxygen in normal human being also. Whenever I think about the sleep-related breathing disorder, it is basically characterized by some sort of respiratory abnormality during sleep. Broadly, it has been divided 3 types. One is about the sum of snoring or upper airway resistance syndrome, obstructive sleep apnea, central apnea, chain stroke breathing, and obesity hyperventilation syndrome. There are 2 to 3 more sleep disorder breathing also there, but out of all, major component about OSA, obstructive sleep apnea. Probably, whatever the situation I talk, the disease I talk, probably this is a natural progression disease. Probably, it is one of the hypotheses. Probably, initially the disease or a disorder starts with snoring, followed by some sort of upper airway resistance syndrome, followed by sleep apnea and hyperventilation syndrome, so and so. Coming to the most commonest symptoms or disorder is snoring. You see, everybody in the house might have experienced some sort of either as a bed partner or as such being a snorer also. That's why the normal prevalence in community is about say 19 to 37%. But ventilator effort is present. As my previous speaker, Dr. Sorin, already explained about little bit. Just I want to highlight, just you see in the obstructive sleep apnea, the airflow is 0 or so to say absent. But effort breathing means effort is there, the chest wall breathing or chest movement or abdominal wall movement is present. That means there is no airflow is absent or nearly absent, but effort is there. That's why, what is the cause? Main cause responsible for obstructive sleep apnea is either complete or nearly complete upper airway obstruction. Second part about the central apnea. Central apnea, same things, airflow is absent. In addition to absence of airflow, there is also no effort of breathing. Means both chest wall movement is absent as well as abdominal movement, both airflow absent, no respiration effort, both chest wall as well as abdominal wall. That's why it is also central apnea. Next part about the upper respiratory or upper airways resistance syndrome or UARS. This is a type of breathing disorder where neither fit to sleep apnea nor fit to hypopnea. What I mean to say, there is a repeated arousal due to upper airway resistance, which is called as a respiratory effort related arousal, leads to excessive daytime sleepiness or fatigueness. But mainly what happens in this group of disorder, neither having hypoxia nor having any say clear-cut apnea or hypopnea. But there is some sort of arousal is there. That's why it is having clinical significance is there. Next severe variety, we can tell it is a obesity hyperventilation syndrome, where gradually it's a patient having the morbid obese like BMI more than 45, and also carbon dioxide PaCO2 level is more than 10 millimeter increase during the sleep. This is frequently and most commonly more than 95% of obesity hyperventilation syndrome are usually associated with OSA, obstructive sleep apnea. Next is how common it is, means frequency or prevalence is how. Just I want to, this is all of the available Indian epidemiological data. You can see the roughly around starts from the male, is male person having more frequently episode than the female. This starts from 2.6% to roughly around 10.8%. But you see this last part is at about the 2008 by Surya et al. You see about the child in children, the percentage of male and female almost same. Like that also in elderly individual, the frequency is same male and female. But in adult population, the male population is comparatively higher than the female. That's why the male gender little bit high risk of obesity OSA in compared to female, particularly in adult groups. But here this few points I want to highlight here particularly. You see, about 15 to 20% of general population had moderate to severe OSA, but without any symptom. That's the issue. That means if you see this study, it has been seen that hardly 3.6% patient of OSA are diagnosed and on treatment. What I mean to say, more than 40, say I think more than 40% of in this study having some sort of HI index more than 5, but still hardly 4% are diagnosed. That means more than 30% of cases of OSA we are not able to diagnose or not put on treatment. And most important part is there, the 15 to 20% of general population having some sort of OSA, but without any symptoms. That is the issue. Coming to the risk factor, already many times many of the speakers already told about this, but important factor is obesity, obesity, obesity. Next part is about some sort of craniofacial abnormality. You know, in upper airway, usually covered by some cranium, particularly maxilla, say mandible and base of skull, as well as some part of cervical vertebra. These abnormality, particularly either abnormality of mandible or maxilla, may having some compromising airways diameter that leads to the OSA. Rest of you know about the risk factor. How could you diagnose? Unless we have to suspect, very difficult to diagnose. That's why we need to have more aware about the symptoms, signs, or the consequences due to the OSA. The best way, history, as my previous speaker already told, and the gold standard of diagnosis by polysomnography or sleep test. What are the classical symptoms? This is one of the disease where we need to take the history not only from the patient, but also from the bed partner of the patient. That's why this is the one of the disease where we need to take the history both for the patient as well as bed partner of the patient. Because some sort of history is there, cannot express by the patient or cannot tell by the patient. That's why we need to know that whenever we will take the history, we will ask the bed partner of the patient. Then only we can take the proper history. Like about the witness apnea, restless sleep, profuse sweating, choking, so and so. Out of all, most important part is snoring and witness apnea. And second most neglected part here is about the nocturia. Nocturia, frequency of urination at night. That is one of the important neglected part history. Second, about the daytime symptoms, as already told my previous speaker about the say excessive daytime sleepiness, morning headache, lack of concentration to the work, as well as dry thoughts, and depression, irritability, and so on. Then this part also important because whenever we are assessing daytime sleepiness, we need to ask history both from the patient as well as family members. And some of the immediate side effect or immediate consequence of OSA, as you have told about the excessive daytime sleepiness, which lead to the auto crash or near missing crash or accident and so and so. This part, some of the scoring already told my previous speaker, like EP sleepiness scale or any Berlin's questionnaire. Lastly, also stop bank score. It is a very useful stop bank score, which we can use this in our OPD practice also by this mnemonics STOP, BA, and G like that. If 0 to 2, then chance of OSA is low risk, more than 5 is high risk. Physical examination that already explained. Only important part I want to highlight here, few points here about the BMI as well as neck circumference. If a neck circumference is more than 70 inches by the male, for the male and 16 inches for the female, the more chance of OSA. Why? Because our Indian ethnicity having a chance of truncal obesity is reflect in the neck also. That's why this is one of the important correlating factor. We can measure the neck circumference based on this. We can predict also OSA. Next part about some of the examination finding already told. Just I want to highlight some pictorial presentation like macroglossia. Macroglossia in the large tongue can be manifested. What happens? Our mouth cavity is not accommodated properly the tongue. That's why some of the indirect evidence like tongue ridge or any teeth mark in the base of the or side of the tongue, based on that we can predict probably this is a macroglossia, because there is no objective measurement of tongue, how much it will be, say a deadline or marking how much centimeter or diameter, or more than that we can tell it is a macroglossia. But it is a relative phenomena. What I mean to say, if there is a tongue is not fit to the mouth cavity, more than the mouth cavity, then it is a macroglossia. Then about already told about the modified Mallampati score. Based on that also we can predict, I mean to say class 3 and 4 are more prone for OSA. This score also can be let's say a well practiced in our OPD also, just to highlight about the orifice size of the pharynx so that we can predict. Then how we will proceed for the investigation? There are already told by our previous speaker the 4 methods of diagnostic method of sleep test, like in-lab full night polysomnography or in-lab split night study. Third part, just I want to give one point extra. This is a home diagnostic polysomnography. This is the same type of polysomnography like level 1, but it is unattended. But the level 2, so to say. But number of channel used in this almost same. But probably this could be a better option in some group of patients where there is being first night effect. I mean to say, people are thought probably in lab study the patient may not got the natural sleep. That's why we can do a sleep state or sleep study at the patient's own home, so that the natural or he or she get a natural environment for the complete sleep. Lastly, polygraphy, this type of a level 3 study where EEG pattern, EEG channel will be not there, only nasal flow, pulse oximetry, and chest wall movement. We can, by 3 parameter, we can judge whether it is having OSA or not. But problem here, Ian, there is no EEG. So that's why we could not identify the type of sleep, what type of sleep, or or posture of sleep, so and so. Next, about severity, already told by previous speaker, AHI index, apnea, hypoapnea index, less than 5 is the normal, 5 to 15 is mild, 15 to 30 is moderate, more than 30 is severe. Coming to some of the pathogenesis where probably if you understand in better pathogenesis, probably we can treat in better way. Say, whenever, as I have told you, the main cause of OSA is the compromission of the upper airways. And how our normal healthy human beings, how our airways, upper airways is patent. These are some of the factor, important factor. One is about the presence of pharyngeal dilator muscle. You see here in picture, this is a genioglossus or tongue muscle, where one of the important pharyngeal dilator muscle, which on contraction it will pull the trunk towards the mandible, so that there will be space is more. Because this space is formed, particularly the upper airways space mainly, there is a nasopharynx, this is oropharynx, this is hypopharynx. This particular tongue is a muscular structure. This is one of the important pharyngeal dilator muscle responsible for patency of upper airways. Next, about the lung expansion. Some of the theory, suppose a patient having say macroglossia, large tongue, say people thought that probably after surgery, say we will modify the tongue size. Can it prevented? Based on few study, it has been seen that even after surgery also still patient having OSA. What might be the cause? This hypothesis coming up like the lung expansion. What I mean to say, the person having large functional volume, FRC, large FRC, those having her lung volume is huge or large, there's having more traction toward the upper airways so that it will be stiff, prevent the collapse of upper airways. In contrary, suppose a patient having a, say, obese patient, so comparatively lung volume is less. In this group of patients having the traction force towards the traction of the upper airway is less. That's why probably more prone for collapsibility. Last part about some of the important tonic muscles like tensor valley palatini, where it is situated just to elevate this soft palate, also somewhat responsible for dilatation or patency of the upper airways. Like also there is some factor which promote the airway collapse like negative pressure during inspiration as well as some extramural positive pressure like fat deposition or some sort of maxillofacial abnormality like micrognathia or retrognathia and so and so. Based on that only we can formulate our treatment. But basically not necessarily one patient of OSA can have a one pathology, may have a multiple pathology. That's why OSA is characterized by a partial or complete collapse of upper airways during the sleep. This collapse is during sleep not in wakefulness because there is a loss of wakefulness drive due to a neuromuscular. Next part about the, there is a complex interaction, pathogenesis of OSA is due to interaction between these both deficient of upper airway anatomy, affect the sleep in upper airway as well as some sort of lung function like as I have told you, large lung size or small size or something like that. Next come to the about the treatment part. Treatment part one important, when we should treat. There is indication of treatment. Means suppose a patient having, as we have discussed about the AHI index, apnea, hypopnea index, 5 to less than 5 is normal, 5 to 15, 15 to 30, more than 30, like that. But particularly if a patient having AHI index more than 15, what I mean to say, both moderate as well as severe variety of obstructive sleep apnea needs treatment. Even some mild grade of OHA also, a mild grade of AHI may treat also necessary if having some significant symptoms. Most important and validated study based on the evidence that CPAP means continuous positive airway pressure is definitely the first treatment of choice in all freshly diagnosed case of moderate to severe obstructive sleep apnea. But in mild case, probably we need some other treatment. But as I have described, in mild OSA also, if patient having symptomatic, still we need to treat them. How it helps? Basically in PAP therapy means positive airway pressure therapy. It is a pneumatic splint, as I have told you, the most commonest common mechanism or pathogenesis is the collapse of upper airway. This positive pressure is act as a pneumatic splint. Second part of mechanism is, as I have told you, once by giving the positive airway pressure, this FRC causes traction of this increased FRCs causes more traction of the neck muscles, particularly upper airways. This prevents the collapsibility. Last part about the volume, increase the airway volume, which also somewhat decrease the pharyngeal edema that may help for the treatment of OSA. There are some other indication or other mode of therapy is also available, particularly oral appliance as well as surgery. But this is some secondary. For example, oral appliance role is very minimal, particularly indicated when there is mild or moderate degree. But suppose patient didn't want to take CPAP in spite of good counseling, still it may helpful sometimes. But in surgery also not a first line treatment, still reserved as a second line treatment in particular condition, in correctable condition, surgically correctable condition. We can advocate like that also. Next part of my talk is what happens if you will not treat. You see this is the ray diagram, but just I want to highlight that already all speaker already spoke about this, what of the complication if you will not treat the OSA. Out of most common complication is cardiovascular complication. Second part is metabolic complication. In cardiovascular complication, particularly hypertension, coronary artery disease, stroke, and atrial fibrillation, and metabolic part about obesity, dyslipidemia, as well as insulin-resistant diabetes. And Madam already told about cognitive dysfunction. It is the most important part also. Based on the previous study, you see the prevalence. The atrial hypertension is 30 to 60%. Means it is a common practice. If a person using more than 3 antihypertensive drug, means definitely you go for sleep study for this patient. This is very much important. Like that also, if a person requirement on insulin is very high, still we need to evaluate the person for the OSA. So like that also, these are the frequency. You see how much 30 to 60% prevalent in pulmonary hypertension in OSA. The second part about I want to highlight this part about COPD. There are diseases like obstructive airway disease like our COPD and bronchial asthma. This also some sort of say nocturnal hypoxia or sleep related hypoventilation can be seen in this group of patients. In what we see in our field, we are seeing the patient at OPD in awaking state. Suppose a patient of COPD patient come to OPD having a stable saturation. Subsequently, we follow the case. So after 6 months or 1 year, we came to know that patient having hypoxia. But based on the evidence, it has been seen that this hypoxia or hypoventilation usually appear sleep only quite before we observe an awaking state. That is the important. What I mean to say, you see, nocturnal hypoxia in COPD patients, 70% of COPD patients at daytime saturation is 90 to 95%, but still having hypoxia. Like that also, 43% of COPD patients having sleep-related hypoventilation. It is a very important issue. That's why it is a quite interesting case, interesting theory that if you identify these group of patients as early as possible, then we can treat them properly. Probably this COPD group of patients may not land in classical core pulmonary or right heart failure. This is all about our study. Finally, my take-home message, sleep-related breathing disorder is very much common in community. Both structural as well as functional risk factor associated with obstructive sleep apnea. CPAP is the best option for OSA. We can think of surgery, if some correctable structural abnormality if present in particular some group of OSA patient. Full night sleep study is a first investigation of choice to confirm the obstructive sleep apnea. Natural history of OSA having both immediate, as told my previous speaker, like cognitive impairment, and late complication as we have discussed about hypertension, coronary artery disease, diabetes, obesity, so and so. Thank you so much for patience hearing.
Good afternoon to all. Thank you, Dr. Sudarshan, for a nice, elaborately discussing about the causes, consequences and management of the OSA. Thank you, sir. particularly the complication.
Thank you, sir, for this wonderful information and very valuable information regarding sleep-related breathing disorders. Now I would like to request Dr. P. Sarat Chandra sir to kindly felicitate Professor Dr. Sudarshan Pothal sir with a token of appreciation. Thank you, sir. Now I would like to request to proceed for a tea break for next 10 minutes.
We have another set. So here, just a minute, you have already bared with us for so long, just we'll take 5 to 10 minutes, because after this we have post-test and demonstration of PAP, positive air pressure, we are ready with it. So by the time you finish your post-test and tea, we'll be ready with the PAP titration. They will show you how we use PAP machines and how it looks like, and what is the pressure, how do we change it, that's all. And after that, we'll have a photo session. That's very important, and a certificate ceremony that will finish. And something is waiting for you. Ama Kottakia Rabidi Lassi is waiting for you. So do have that. It is handmade. Bhalla Lassi, jo Rabidi Podiki jo hue, please go and have it. Feel fresh. By that time, we'll be ready with the next 15 to 20 minutes we have. तमें जाइके आराम से चा लस्सी भलरे खाई के आसो ता भीतर सब हो जिवो. Please enjoy. I told you 2 things, food and sleep. Physiology is famous for it. I have learnt it from my gurus, and I am just passing it to you.